the consultation station, which actually constitute two stations and carries the most marks based on the distribution. So we will just go through a bit on the briefing before we start. So as you can see, now we have 20 minutes and 5 minutes with the examiner in terms of the questioning. But generally, you also have 5 minutes to prepare outside the scenario instead of just for two scenario, we just 2 minutes each. And you can see that this is the proposed kind of allocation. There's no fixed timing that we have to obey or adhere. But generally, I would advise for history taking component, you should spend about 8 minutes, 8 to 9 minutes. And then examination, probably you can spend about 4 to 5 minutes. And the concern, you must leave it a bit more because as compared to the previous format, the new format actually will have more concern. You can see that in the sample cases that was uploaded in the official website. You can see that they have 5 or 6 concern instead of just 2 to 3 concern. So I would say that for concern part and also explanation on the patient diagnosis, we need to spend a bit more time. So I will give a 3 minutes instead of 2 minutes. But examiner may still warn you at the last 2 minutes. That one is not confirmed yet because they are still changing. But generally, we try to ask the concern after we finish examination, and then if you feel time is almost there. If you want to wait for the full 2 minutes reminder, you can wait for it. But please make sure that you don't miss anything from the history examination because this part of the session is when you really need to sit down and talk to the patient and explain and answer the patient concern. You cannot be examining the patient and asking the concern. It is not very appropriate. So let's see. So this is what the general guideline. I mean, the general outline, the proposed allocation is like 8, 4, and 3, like I mentioned. And if you look at the latest sample scenario, also under the title of the question stem, you will see that there's a few agenda that examiner are expecting us to do, and these are all already listed when we are sitting outside. The first is actually they mentioned that we have not necessary to complete history before examining patient, meaning to say that we can be jumpy, we can ask a bit of history and then HOPI, and then if you think very crucial for you to guide for further history, you can examine the patient a bit and then you continue back the history and you examine a bit. And the next thing is actually you are expected to actually explain what was the probable diagnosis and list out the management plan for the patient. So they are expecting us to do more than just the previous BCC, in which we should actually explain what the patient has, even if the patient didn't tell, but most of the time the concern the patient will ask. But even if the patient didn't tell, you should straight away address the concern and answer the patient and tell the patient that I think you have likely diagnosis of this, and this. And I'm going to order some blood tests, going to order some tests, or I'm going to admit you, or can work you out as outpatient and see you back in clinic. So you must give a brief general plan, or you can say that you want to refer to multidisciplinary team for further management. So I think that part need to be mentioned as well because it's part of the agenda that we are expected to do. And the next thing is actually to discuss the option with the patient and agreement of management. So you will expect sometimes the concern that was listed and designed by the vetting community is they will talk a little bit and ask a little bit on the management from the patient point of view. So let's say you think the patient need to counsel for lumbar puncture. Let's say this is meningoencephalitis. So you say that I probably need to admit you and may need to take a sampling of your brain fluid. How you think about that? So the question, part of the concern, the surrogate or the patient may actually ask, "Oh, I don't want lumbar puncture. Is there anything else?" So we are expected to kind of like discuss the option. If it being asked, you can say that we'll talk in detail about this. I think it's quite overwhelmed for this session, but generally you can admit to the board and we will talk about it in detail. And if we really refuse, there's also a possibility of doing a brain imaging. However, it also carry risk of contrast because we are giving dye, things like that. But you don't need to go straight away full gear to the com skill station. We are not particularly focusing on com skill. But this is just something that we are expected to do. Let's say we need to negotiate and provide option for the patient. And the last agenda they give is actually they expect us to answer all the concern and then to assess the view of the patient issue. And that view in which the patient idea should include non-medical aspect. So for this newer format of consultation, we are expecting that patient will have some other issue instead of just medical issue. For example, patient will have issue with work. For example, patient will have issues in terms of relationship or family members or in terms of finance. So to target this, we should ask a bit more during our social history, and we should need to offer something like, for example, if occupational issue cannot work, need to modify, may need to refer to occupational health service, talk to the employer. If let's say got financial issue, caretaker issue, staying alone, we need to refer to the welfare. You can mention all that first. I mean, if you mention all these things upfront to the patient during the discussion with the examiner, they won't usually uh, uh, expect you to answer again all this. Okay, but this is something that we need to target. And the last point is actually perhaps the most important thing is to always ask them, perhaps if you got no other question to ask them, you should ask them what actually matters most to you. What is the main issue? What is the main problem that you're experiencing? So all these things are not created by me. It's all created by the RCP, and we are expected to fulfill these 4 criteria. So they are not very particular in the sense of sequence. Let's say we need to ask history first, then examine the patient, then only ask about concern. But generally, I'm a bit old school. I'm being taught by my tutor Hassan before, and some other tutor as well. We are generally a bit more old school in the sense that we tends to believe more on history, because in our medical school time is the same. History constitute 80% of the diagnosis, and remaining 20 to 10% is to examine the patient as well as to carry out the proper investigation. So to me, if we are unable to get a proper history, the problem comes is when we examine the patient, we won't know what we are looking for and what are the signs that the examiner actually try to calibrate. So this is actually an issue to me. That's why I feel it's still better, still safe to spend a good amount of time to take history. Let's say if you want to take history, you worry you cannot finish examination, probably you can wait until 6 to 8 minutes, roughly. Then you start to examine the patient. Then while examining the patient or even finishing the examination, you can ask further like the least important history, for example, social history, family history, or other thing, drug history. Generally, I will try to ask presenting complaint, history of presenting complaint, past medical history, drug history, or if female, I will ask about female history. Only then I will examine the patient. I think that will be my idea. But I think everyone approach cases differently. There's no right or wrong, but that's the approach that I feel is the safest, because a lot of times the drug history and also the female history or even past medical history is the one that gives us a clue towards the diagnosis, and we need to perform certain examination, a targeted examination, in order for us to confirm our diagnosis. So that's why I think it's still safer to wait until really reach finish the female history or drug history. Only then you examine the patient. Okay, so let's start with the first candidate for practice. I think Dr. Nick, right? Can you unmute yourself?
Hello, can you hear me?
Yes, yes, I can hear you. So I think I started recording for this session just to benefit everyone want to listen back, or anyone that cannot join this session, because I think we only got like 29 participants. This is something usual because weekend a lot of people are also working. So for you, I will start a timer for you. You are the first one that using this new format. Have you before I just begin, I just want to know, have you practiced this format before?
No, not yet.
So this is the first time you're trying this, right?
First time.
Yeah. So in fact, a lot of examiner during the last briefing, our local examiner with the RCP in Penang, it was like almost 1 month ago. So that time also everyone is new, including the examiner and also the candidate. So the candidate, they actually choose from those that going for exam. I think it's from Penang or other center also. Typing also got, I think, if I'm not mistaken. But anyway, actually they tend to modify just almost same as our previous format. It's just that they lengthen it, they make the scenario a bit more complex, and just to buy some time for us to explore more and then examine more. So in this for all the participants that going to do the clinical consultation for today, please bear in mind that during the examination part, you will expect, I mean, because this is just a virtual thing, you must say out what you want to examine. And then I mean drag a bit of time for you to, I mean, just like real life practice to spend a bit more time before I tell you the finding. And for all scenario that I have prepared, so the scenario actually don't have uh I don't have photo for the sign or anything. So it's like you are seeing a virtual patient, but you're expecting to examine a patient that have some sign. They will have I mean the scenario will have some positive sign, okay, for me to calibrate. So but you need to ask and you need to examine and you need to tell what you want to examine. Okay, so you spend good amount of time to examine patient, about 3 to 4 minutes. At least I feel we should examine at least 3 minutes. And regardless of what system you want to go for, you can just touch here and there, but make sure you get at least a bit of sign, and then only then you ask about concern. So you are ready to start, right, Dr. Nick?
Yeah, ready.
So I will give you 5 minutes to prepare. Your time start now. Okay, Dr. Nick, your time's up. This is Madam Susan. Please start.
Okay, good morning. Good morning. My name is Dr. Nick, one of the doctors in the outpatient clinic today. May I just confirm your name and age, please?
Yeah, I'm Madam Susan. I'm 40 this year.
Very nice to meet you, Madam Susan. I hope you didn't have to wait too long to see me today. May
Yeah,
I ask what brought you into the clinic today?
yeah, doctor. I've been having breathlessness for the past 3 months. I feel it's getting worse. I'm worried. Is there something wrong with my body?
Oh, I'm sorry to hear that. Can you tell me a little bit more about this breathlessness?
Yeah, so this breathlessness has been there for almost 3 months now, and it started initially. I having breathless when especially when I go to work early in the morning, and then throughout the course of the day, I feel it's actually getting better, and then I still able to sleep at night. That was the initial presentation. Subsequently, I realized that I'm getting this breathlessness episode getting more frequent, and it comes and go like a wave. I'm getting worried.
Oh, I see. And is this the first time that you've been having this breathlessness?
Not really, doctor. I actually have asthma, and this asthma already been with me since young. And I also experienced similar kind of breathlessness. It's just that previously was not frequent like this. Now it's getting worse, doctor.
I see. And is there anything that makes it particularly worse?
I don't know. Like you say, I I tend to realize that this breathlessness comes especially in the morning. And then after towards the evening, after I come back at home, I feel okay. I mean, somehow it's okay. I don't feel any issues.
I see. And is there anything that makes it better?
Not particularly that I know of, but I know that if I take my inhaler more frequent as well, it tends to relieve the symptom.
I see. So you find that you're having to use your inhaler more frequently.
Yeah, yeah.
I see. And is there any noisy breathing associated when you have this breathlessness?
Yes, yes. There's noisy breathing.
Does it sound like a wheeze that you had previously?
I think it's called a vis. Yeah.
I see. And how many times are you using your inhaler every day?
So I am using two types of inhaler. One is the purple type. It's called Serotype. I use every day. I use about twice, morning and night. It's about each. I use two puffs. And the other
Okay.
one is the Salbutamol. That one I actually use a lot recently. I use like 7 to 8 times per day.
Oh dear, that is a lot. And previously your asthma was never this bad?
Yeah, I mean I have asthma about 10 years ago. And that time, I was also having this kind of breathlessness. However, the doctor, after starting me on the inhalers, it tends to get better. I don't really have any serious, this kind of attack in the past.
Have you been hospitalized in the past few months?
Hospitalized, I think no, but I went to emergency department for a few times for the past 3 months. They have given me a gas, and then after that I can be discharged. I don't need to be admitted.
I see. So just going back to your breathlessness, is there any coughing that comes with it?
Yeah, in the morning I tend to have a bit of cough, but generally I don't have any phlegm. It feels like my throat is dry.
Oh, so it's just a dry cough. Any runny nose?
Yes, in the morning when I wake up, I feel my nose is actually wet. But other than that, I don't feel any runny nose throughout the day.
Is there any particular sort of triggers that makes it worse, such as exposure to dust or any pets? Does that make this breathlessness worse?
No, no, I don't wear pads, and my house is very clean. I always clean my house, and I also have my maid to clean all the furniture and also the dust.
Uh, okay, and do you find that with this breathlessness that you cannot walk as far as you used to?
Yeah, doctor. This because of this breathlessness, I'm scared because every time I go outside to buy stuff or to work I feel I may short of breath one day and I cannot walk back to my home, and then I feel this is very serious, doctor.
No, yeah, it does sound very bad. Um, any swelling of your legs?
No, no,
Do you have any difficulty lying flat at night?
no.
Do you notice any change in your weight?
No.
Any change in your appetite?
No.
Any fevers?
No.
Any sweating at night?
No.
And have you ever kept a diary of your symptoms?
No, not really.
Not really. And the shortness of breath you mentioned is worse in the morning.
Mm.
Okay, just going to ask a few general questions. Have you ever had chest pain that comes with the shortness of breath?
No, but if I cough a bit more, then I may feel a bit of this pain. But generally, it doesn't persist.
I see. Any tummy pain?
No.
Any problems with your bowels or your waterworks?
No.
Do you notice any lumps or bumps over your body?
No.
Any changes in your skin?
Changes like?
Do you notice any white spots or any rashes?
No.
Any itching?
No.
Uh, any joint pains?
Joint pain? Not really.
Any body aches?
No.
Has anybody commented that you're paler than usual?
No.
So apart from asthma, do you have any other medical problems?
Not really. I only have asthma. I'm quite healthy, I think.
I see. Any allergies?
Yeah, doctor. I tend to have allergy to some for example prawns. So some seafood, in particular prawns lah. So I try to avoid taking that. If other than that, I don't have any medication allergy that I know of.
So apart from Sereta and Salbutamol, are you on any other medication?
No, no.
And may I ask, what do you do for a living?
I'm actually working as a baker, and I mix a lot of breads in my bakery. So it has already been that, I mean, I'm working as a baker for the past 5 years already lah, and I don't have any issue until recently.
I see. So your shortness of breath is not worse at work.
At work, as in,
When you go to work, when you're baking, do you find that the shortness of breath is worse?
not. I mean, I'm not sure because I tend to get shortness of breath in the morning, like I say, and then towards the evening I'll feel better.
I see. And do you smoke at all?
No, no. But my husband actually smoke.
I see. And does he smoke in the house?
No, he's not smoking in the house. But sometimes I do smell the smoke also lah.
I see. And apart from that, do you have any concerns at all about your breathlessness?
Concern ah. Yeah, I'm just worried. What I might have, doctor.
I see. Okay. Is it okay if I examine you and then we'll get back to your main concern?
Yeah, sure.
So may I have a look at your hands first?
Yeah, that's patient show you the hand. You want to look for what?
Any clubbing?
No clubbing.
Any rash? Any
No,
any swollen or tender joints?
no.
Any signs of cyanosis?
Signs of what? Cyanosis.
Yeah.
Signs of cyanosis.
So
No, the hand looks quite red and there's no cyanosis.
okay. Any conjunctival so moving to the face, any conjunctival pallor?
No.
Just gonna examine the lungs. Just auscultating from top to bottom.
Okay. You want to proceed with auscultation first?
Yeah.
Okay. So on auscultation, as you go examine from the lung, upper zone, both side, and middle side and the lower side, you found that there is generally prolonged expiratory phase with expiratory bronchi.
And what's the respiratory rate?
Examiner tell you the respiratory rate is about 18 breath per minute.
Breath per minute. And equal air entry.
Breath sound is equal.
Chest expansion.
Yeah, so you want to do chest expansion, you do from the top to bottom is equal but seems reduced symmetrically.
Symmetrically reduced. Okay. Moving to the auscultation of the heart sound. Any any loud P2?
No lapitu,
Any parasternal heave?
no parasternal heave,
Any signs of sacral or peripheral edema? Either edema, sorry.
no. Anything else?
And there's no rashes anywhere.
No, you don't find any obvious rashes?
Any cervical lymphadenopathy?
Okay, good. When you examine the patient neck, there is no palpable cervical lymph nodes.
And when I examine the hand, there's no tremor as well.
No, there's no tremor.
Okay, getting back to your concern, Madam Susan,
Mm.
you asked me regarding what might be the cause. Am I right?
Yeah, doctor.
So from the sounds of it, it sounds that having to use your inhaler quite frequently and your symptoms happen in the morning.
Mm.
It's possible that actually your treatment for asthma is not as good as it used to be, signifying that the control of your asthma is not very good.
Oh,
So I suspect that we might need to have a change of your medication and possibly add a few medications
mm.
to help you with this breathlessness.
I mean, what is the cause of this uncontrolled asthma?
I suspect because you mentioned to me that the shortness of breath is usually in the morning,
Mm.
and you do work as a baker. I'm worried that actually exposure to the dust or any sort of like powder or flour that happens at your bakery, perhaps that's what's causing your asthma to get gradually more uncontrolled.
Oh,
It's a
but it has already been 5 years, doctor. Is it still possible?
It is possible actually because it seems that from your history, the fact that you have allergies and you've had asthma from a young age, it could be that you are one of these people who are sensitive, or we call it uh, sort of like allergic to dust that happens gradually, and it
Mm.
could be that this is one of the reasons why. However, having said that, I would like to perform a few tests on you first before we commit to that as the final diagnosis.
Doctor, do I need to be admitted? I feel very breathless. I'm very worried now.
Actually, I do think that you do warrant for admission. Number one is because looking at your the level of oxygen in your blood is about borderline at 94%, and it is very worrying to me that you are finding it difficult to even walk to work and back, and the fact that you're using your inhalers up to 7 times, your salbutamol inhaler up to 7 times, and when I had to listen to your lungs, it sounds your asthma is flaring up at the moment. So I do believe that you would benefit from an admission just for us to get a handle on the breathlessness and give us an opportunity to do more tests so that we can get to the bottom of this. Would that,
Two
does
minutes
that
left.
does that sound okay for you, Madam Susan?
Yeah, okay. I'm very happy. I want to be admitted. But doctor, can I continue to work?
Uh, at the moment, I don't see why not. However, as I mentioned, I would like to get to the bottom of this diagnosis first. And once we optimize your medication and you are less breathless and you can carry out all your activities, including walking to and from work, then I think you can go back to work.
Oh, okay. Will my condition gets better with the improvement in terms of the medication?
We do hope so, but do bear with us because I think that might need some time for us to add some medication and for us to monitor your response to that medication. So it might take some time before you feel like yourself again.
Okay. Doctor, my friend was diagnosed with lung cancer recently. Is it possible that I have this possible condition?
Uh, it is a possibility. However, from the history, so if you were to be having a diagnosis of cancer, you would have other symptoms. But from the history and from my examination today, I think it's less likely.
Okay, doctor.
Do you have any other concerns for me today?
Yeah, you say I'm going to be admitted. What are you going to do for me?
So firstly, I would like to start you on a regular inhaled gas, similar to the one that you had in emergency department previously, just to help with your breathing and your breathlessness. Secondly, I would like to send some blood tests to make sure that you don't have a concomitant infection at the moment. we'll do a few scans to have a for me to have a better idea of what's going on in your lungs. And
What
then
kind of doctor? Because I'm actually planning for pregnancy. I don't want to be to undergo any the scan that have radiation. Okay, time's up. Okay, so you have 5 minutes for examiner. So Dr. Nick, would you mind to go through your differential diagnosis and tell me about your possible diagnosis in this patient?
So my top differentials for this patient who's a 40-year-old who complaining of progressively worsening breathlessness in the morning with a background of asthma, but what seems to be uncontrolled asthma with a reduced effort tolerance, daily symptoms, and increasing use of salbutamol. So my
Mm.
top differential would be uncontrolled asthma,
Mm.
likely secondary to under medication. But other important differentials would be allergic asthma
Allergic
or
asthma as in?
uh, what's that?
Mm-hmm.
Occupational asthma. Is it the one that's
Oh,
related to
uh, you have mentioned, okay, is there any other differential diagnosis?
uh, other important differentials would actually be interstitial lung disease, and at the bottom of my differential will be COPD.
COPD because of the passive husband.
Yeah, history of passive smoking.
I see, I see. Okay. So you have mentioned that the first diagnosis was under medication. Have
Mm-hmm.
you assessed patient inhaler compliance and also the technique?
Oh no.
Do you think it's important?
Yes, it's very important.
Okay. Then you have mentioned possibility of occupational asthma. Do you have enough information to tell you this is occupational asthma?
No. It's just from the history of assumption that she's a baker, so exposure to like dust of flour at the bakery, and that the symptoms coincide in the morning, which I assume is when she goes to work.
I see. Then what do you know of diagnostic criteria for occupational asthma? What are the criteria that from the history can tell you that this is occupational asthma?
It's symptoms that are worse on going to work and are better when they are not exposed to work.
Mm-hmm. Any other history?
Hmm. I'm not sure.
Sorry?
Not sure. I think that's it.
Okay. How will you investigate for this patient? You have mentioned a few to the patient that you want to admit the patient. And what are the tests that you want to order for this patient?
So firstly, because the saturations are 94%, quite borderline, and the patient is having prolonged expiratory phase and bronchi. So firstly, I would like to order an ABG just to
Mm.
look at what is the blood gas and partial pressure of oxygen levels. Secondly, I would like to do a bedside peak flow just for me to know what is the expected and what is the baseline so that we can categorize this patient's asthma as mild, moderate, or severe. Then I would like to order a full blood count to rule out any signs of infection. Looking at total white. Next, I would like to do baseline renal as well as liver function test just to have a baseline prior to starting any medication. In terms of imaging, I would like to do a chest X-ray to rule out any consolidation, any concomitant pneumonia. Also looking to see whether there's any reticulonodular shadowing or fibrosis that will suggest interstitial lung disease.
Mm-hmm. Anything,
Uh, Pardon?
anything else? You
That's
have
for
mentioned
the,
you have mentioned the patient oxygen level is low, right?
yeah.
So anything else you want to order? Hello?
Hello, yeah, sorry. AVG, chest X-ray, peak flow.
Okay. How about any specific tests for you to know whether this is so-called occupational asthma?
You mean at the acute setting or in the non-acute setting once the exacerbation is more controlled?
Hmm.
Then spirometry with reversibility.
Okay. Anything else?
Also looking at IgE levels.
Okay. So how will you manage this patient on top of just oxygen and then optimizing the inhaler? Is there anything also important in this context? Hello?
Yeah, so apart from optimizing the medication and checking for inhaler technique,
Time's up.
uh,
Time's up. I think you face out a bit.
yeah,
Yeah. So this can be common like in real exam, certain examiner today I choose not to be a good not a good examiner. Today I choose to be a very emotional examiner. This is what usually happens when the examiner asks you question. If they don't want to hint you, they will just keep silent. And then you're going to be continuously silent until you say something. So some examiner they are very helpful. They really want you to score. They will ask you question. They will keep hinting you. But some examiner like what I did just now, they will not mention anything, and they will keep asking anything else until they get the answer that they want. Oh? So when you know that the examiner asks you anything else, maybe you will know that you don't. I mean, you did not able to answer the answer that the examiner want yet. But I think, how was your performance in your opinion?
I
Hmm?
think very nervous lah. First time trying this, and
Hmm.
actually 15 minutes is very long.
It's very long, but I think I think you just enough time, right?
Yeah,
Hmm.
yeah.
So this is a scenario of occupational asthma, huh? But
Mm,
just before we go into discussion, I think your history need to be a bit more organized. At the same time, you really need to go in detail on the HOPI first and exclude a differential diagnosis and screen for systemic review. Only then you try to assess the past medical which is the asthma. I know you are very tempted to straight away ask about asthma control, everything to I mean everything in beginning, like what you did. But actually doing that will actually make you lose focus regarding the presentation itself. I
mm,
mean, yes, you try to exclude a lot of things, for example, pets, dust. But if you really ask about the precipitating factor for asthma per se, there's still a few of the things that you didn't manage to ask. Oh, for example, you did not. I mean, you asked me about drugs, right? You asked me about any other drugs, but you didn't ask me about any traditional medication. All
mm,
those things are not routinely being asked unless you ask a specific question. And the thing is, you ask about infection, you ask about fever and cough. Okay, that's good. But you didn't ask me about any exercise. Do you feel the symptom get worse with cold weather? Oh, the very
mm,
common question that you miss. And how about emotional? Some patient with asthma, their symptom actually get worse with emotion, and you didn't really explore how does this presentation impact the patient well-being. Yes, I mentioned that I cannot. I'm very afraid to go out. I'm worried that I will out of breath one day, things like that. But you didn't describe that. How does it affect your work and how does it affect your activity? Okay, you need to ask this question in particular. Sometimes examiner may lose focus that oh you didn't explore that, for example. Okay, and the
mm,
most important thing is actually you didn't ask about compliance. You asked me
mm,
yes to the medication dose I need to take about 7 to 8 times salbutamol, but you didn't ask me whether I really take it daily for maintenance like serotype. You didn't ask me whether I'm compliant to the inhaler or not. And second thing is you really need to assess inhaler technique. We are not expecting to assess inhaler technique during the exam, but you need to ask, have anyone checked your technique? This
mm,
is
okay.
the direct way to ask, right? You just need to ask, we don't need to examine. Have anyone checked your technique before? Is there any issue? Is there any concern? And then is there any worries that may actually make you don't want to take the inhalers as frequently as it should? So you need to really explore on the technique to ask it. And because if you ask about technique, if you remember to do that, then in your examination, you will really want to check for any oral thrust to make sure that the patient is not having oral candidiasis because of the poor technique and because of the inhaler use. Now you see the importance, right?
Mm,
So
yeah.
if you didn't think about it, definitely in the history, you will not examine the patient, you will not look for specific sign. Okay. This patient definitely is important because it's difficult to control asthma. This is a scenario difficult to control asthma, and therefore it's important that you want to look for complication. You also want to look for cushingoid features for this kind of patient.
Mm,
You also ask me whether I'm taking any other medication. you should also, I mean, now, yes, I'm not taking any other medication, but previously when she went for hospital, I'm sure that the doctor will treat her as exacerbation, right? Be
Yeah.
it mild exacerbation. And you should actually explore, did the doctor give her steroid? And the answer definitely is yes. And how frequent she took the steroid. And this is another aspect that you need to explore to make sure that you're not dealing with Cushing, which is part of the complication from difficult to control asthma. However, this is not the target. I mean, it's not the main dish in this scenario. The main dish is to explore why the patient has difficult to control asthma. Let's say she tells you she's compliant and her technique seems good. Yes, one of the top differential diagnosis for this patient is occupational asthma. But to actually diagnose occupational asthma, you need a few criteria. First criteria is exacerbate. There is a diurnal variation in which the symptom get worse at workplace and relief at after out of work. So that also includes when she's back at home. And usually you also need to ask another question, a specific question. Do you went for any traveling, any holiday recently? Do you feel the symptom gets better? Because they usually will have this holiday period in which out of the workplace, the symptom will get better. And the third criteria of occupational asthma is you need to ask at workplace, any of her colleague experience a similar symptom.
Mm, okay.
So in order to diagnose occupational asthma, you really need to get these three things to be there in order to suggest, because patient will not know that the triggering factor is actually at work, and patient does not believe that because it's already 5 years working as a bakery with the same ingredient, no change in terms of the vendor, and how can she get asthma worsening because of that? Patient perception will be like that, so they will not think that this is due to workplace issue, but we need to establish the diurnal variation and the pattern. And if you're able to ask all these questions, then yes, your diagnosis is really occupational asthma. Okay. And your differential diagnosis for this patient, what is the differential diagnosis when you try to ask? You have asked about persistent provocating factor like PACES, drugs, or
Mm,
you ask about occupational asthma. You also try to exclude infection, which include TB, right? As pursued,
yeah.
because you ask about fever, weight loss, also got lumps and bump and night sweat, right?
Yeah.
And yeah, I mean, there's another possibility like allergic bronchopulmonary aspergillosis, which usually you can only find something, any skin lesion. You did ask about that. And then most of the time they may not have any symptom. And then other than that, you also ask a bit of joint pain, a bit of autoimmune symptom to suggest vasculitis, right?
Yeah.
Sharps, EGPA.
Yeah.
Good. And then how about is there any I also realized that you asked about cardiac asthma, you try to exclude heart failure, leg swelling, autopnea. Okay, good. But there's three more diagnoses that you didn't exclude from the differential. And one of these can be quite common and can actually precipitate the asthma. Can you think of any other differential?
Mm, it's sarcoid. Didn't ask, but ask for cough lah. Didn't say. I mean, there's no hemoptysis or any history of sarcoid.
So sarcoid other than cough is very non-specific. Everything can cause cough, right? But for sarcoidosis in particular, it's a
The
hypercalcemia.
hypercalcemia. Oh yeah,
You really
didn't
need to
ask.
ask. You need to
Yeah,
ask
but
whether you pass urine more than usual, you drink water more than usual, you got any tummy pain. You did ask about tummy pain. You did ask any change in your urine or bowel habit. Yes, ask that. But you did ask in detail. Huh?
oh,
And
okay.
usually they will have some erythema nodosum as well. So you want to ask for any painful skin nodule, for example, and you want to check during the examination as well. Okay.
Okay.
Other than that, I mean more common one. Sarcoidosis is not that common in Malaysia. What is more common? Is GI symptom. You didn't explore the full GI symptom for this patient. It's actually the reflux, GERD.
Oh
GERD
yeah,
is one of the
good. Oh
GERD is
yeah.
one of the commonest causes of difficult to control asthma. Okay, so GERD is something very important. You should ask about heartburn. You should ask about you ask about tummy pain, but you didn't ask about any tummy discomfort, any worsening of symptom after eaten a spicy meal, or even is it due to the bloating sensation of your tummy? Do you have any uh we don't use acid brush lah, huh? Do you have any soury taste over your back of your mouth? Things like that. You need to exclude GERD. GERD is common, and therefore
Mm.
they're expecting you to mention that as well. And the last one is perhaps the rare one is the carcinoid in this patient. I mean, in a difficult to control asthma. So carcinoma is something that we need to ponder because they tend to have episodic wheezing, episodic breathlessness. And the other additional question to help you, to give you a clue, is actually the episodic, any facial flushing.
Flushing.
Yes, any facial flushing. And have you ever been told that your blood pressure is high? Do you have any loose stool? I know there's no change in bowel habit, but you did not explore, maybe
Mm.
patient have change in bowel habit for very long until it's normal for patient. So patient will tell
Mm.
you normal. Okay.
Okay.
So when I was a candidate, when I prepare for exam, when I ask any change in urine or bowel habit, I will usually follow the next question is after they say normal also, I will say that is your stool is normal, and then any blood I will routinely ask in detail because I don't want them to bring a perception that sometimes their normal is not normal. Okay, it can be quite tricky sometimes. And the urine also, are you passing more urine or less urine than usual? Is there any pain? Is there any abnormal smell when you pass urine? So I mean, this is like a history slash BCC kind of scenario. We have more time, but your history, judging from the time allocation just now, you spend about 7 minutes to ask history. You spend about 3 minutes to examine patient, which is good. And then subsequently, you answer the patient concern quite long. I think you use about 5 minutes to answer patient concern. You 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 jump into the concerning addressing the concern part quite early because I think you feel that you have no more question to ask. But bear in mind that this patient is a female. You should also explore the female history. Oh, I know sometimes it may not be relevant for the exam, for the diagnosis, but this is something that we should routinely ask. Oh. Sometimes to our surprise, sometimes the patient chief complaint may be related to menses. For example, typical example is headache, intermittent headache. You ask postcoital headache, you ask about migraine, you ask everything. Seems like migraine to you, but you don't know what's the specific factor. Only when you ask female history, you know that this headache actually get worse with every menses. Then you know that actually this is actually catamenial migraine, which is worse with the menses. And this patient, sometimes when they come in exam, this kind of scenario, they won't tell you that they know that, oh, my migraine tends to get worse when I got period. They will just tell you that my migraine actually comes every month. It's a bit vague, but that's why sometimes we need to be a bit more specific. And therefore, sometimes a lot of template-based tracking is still important to just go through and make sure we didn't miss anything. Huh? So this is just some discussion. History, I think you got most of the thing. You got most of the thing. And then examination, yes, I'm actually expecting you to mention this saturation level before you start to examine the patient. Or else you routinely forget. You didn't forget when I asked you, do I need admission? Only then you mention about that. But you should mention it earlier when you examine the patient. Okay? And then yes, you want to look for any rash, any skin lesion like erythema nodosum. And then lungs, yes, this patient is lung and CVS, the targeted examination. Yes, I didn't put here because basically you also need to examine lymph node as well, especially when you got TB. Huh? And differential diagnosis, yes. So this is actually sensitizer induced. Occupational asthma got two types. One is the long latent period, and one is the short latent period. Sensitization, like for example, the FLA, the products, they are all generally longer duration. Okay, so as compared to irritant is actually faster. Irritant is something like choline, organophosphate, like ammonia, and also isocyanate. Isocyanate is also common. And for sensitizer induced, patient can be a painter, and most of the time it's a chemical, which is a diisocyanate and some aldehydes. But usually those enzyme, animal protein, FLA also can cause sensitization. They are more to sensitizer induced asthma instead of irritant. So when the patient asks, can this still be occupational asthma? Can occupational asthma occur on top of bronchial asthma? The answer is yes for both. Sensitizer induced can occur with a latent period up to 10 years. It's a very, very slow acting immunoresponse. So up to 10 years, remember. So that's why 5 years is still possible. And when you come to I didn't include the workout and everything because I just thought it would be easier for me just to mention. The investigation for this patient, because you have mentioned that maybe patient has some sensitization towards bread, right? Works as a bakery. You want to know the animal protein and flour, right? How do you diagnose the trigger? Is to actually do a skin prick test. You're expected to mention skin prick for this kind of scenario. Because by doing a skin prick, you will know that that is exactly the trigger. Okay. And to really quantify to confirm the diagnosis of occupational asthma, you have mentioned peak flow, but peak flow is not enough. You need to mention serial peak flow at the workplace as well as out of the workplace. You need to mention that in specific in order for you to diagnose occupational asthma. Okay. And in this patient, I realized that you didn't mention a very once important investigation in the Fulbert count, which is the eosinophil count. Nowadays, with the advancement of biologics in asthma, we need to know the patient eosinophil count because this will actually help us to stratify the phenotype. Whether patient is actually the very allergic, like you say, the allergic phenotype of asthma, the one with the high eosinophil count. Because may consider in terms of management, if the examiner asks you what else you can offer despite optimizing the inhaler, yeah, you can start some leukotriene receptor antagonists like montelukast, things like that. But eventually you need to mention that you may consider biologics, refer to chest physician. Okay. And then this patient management cannot be stuck one. For all scenario, regardless of short case or consultation, our management should be tip top, should be verbal diarrhea, should not be stopped, should not be stunned. If you cannot think of any management also, after you have offered inhaler, things like that, just mention non-pharmaco, man. Always start with non-pharmaco. Avoid the triggers. For this patient, actually sensitizer induced cannot work as compared to irritant induced. Irritant induced, you can still wear mask, still wear glove. Avoid that, then you still can work. But sensitizer induced asthma, you should ask the patient to change job. Cannot work with the same trigger because the longer the patient being sensitized, the worse the controlled asthma, and the outcome is actually worse. Patient may have a very severe life-threatening asthma like status asthmaticus. So the question is, can I continue to work? Actually, if you're not sure, is to say that I think at this point of time is still unable to decide. I will need to confirm back, order some tests in order to know what particular diagnosis you are. And if it really turn out to be occupation related, there is a risk that you may need to change your job. You should mention just like that, but you don't give a 100% kind of answer because in sensitizer induced, you need to change job. In irritant induced, you just need to wear glove and the PPE thing. Okay, so what I want to say is that yeah, the verbal diarrhea, but the management you should mention really fast and also fluent, and you should mention those that really the tiny things that examiner like to hear. I will involve multidisciplinary team. I will involve to the physiotherapists, occupational therapists. You should mention all that routinely. And for this any respi patient, you should mention vaccination. Very important. You should mention that I will also check whether patient is vaccinated, whether vaccination is up to date, and then you also advise patient to avoid other form of triggers. Okay, so all these things if you mention also you're actually buying some time for your brain to think what are the anything that else that you want to mention. So instead of keeping your brain and your words blank, it's good to just say out something that is very general answer and then generally accepted as like to hear one. Then you tell the specific thing that you forgotten or you are trying to figure out. Okay. So I think that is the case for you. Is there any question for you?
No.
Okay, yeah. I think that's all. We will proceed with the next candidate, yeah. So Dr. Cheong, are you ready? Can you unmute yourself?
Can you hear me?
Yeah, I can hear you.
Okay.
So I will give you 5 minutes to prepare as well.
Okay.
Okay. So let me just set my timing. Okay, your time start now.
Okay, thank you. Feel. Feel out. Feel out. Feel out.
Okay, 5 minutes is up, Dr. Cheong. This is the patient, Mr. Paul.
Okay. Good morning, Mr. Paul. Am I confirm? I'm Dr. Chung here. I'm the one of the medical officer in the emergency department. Okay, I would like to confirm you. Are you Mr. Paul?
Yeah, Mr. Paul.
May I know what is your age?
58.
58 years old. Okay, Mr. Paul. Okay, I'm here to address your issue. Just can you share with me what bring you here to the emergency department today?
Yeah, doctor, I have been having cough for quite some time. For the past 1 week, I'm having cough, and I noticed got blood in my phlegm. I'm very worried, doctor. Am I having any cancer?
Okay, Mr. Paul, I'm so sorry to hear that your problem causing you a lot of distress to use. Let me just give me some time to ask your history and also examination, and then we come to a conclusion to have a better management on you. Is it okay?
Yeah, sure.
Okay, are you okay to continue your conversation?
Yeah.
Okay. So, okay. Okay. I just want to ask a few questions. You told me that you have been coughing for 1 week and coughing out blood. Can you tell me more on that?
Yeah, doctor. I've been having this coughing or blood for 1 week, like you say. Initially, I noticed there's just some speck of this some phlegm that coming out, which is blood streak. But subsequently, recently it have become full blood clot, as well as flash blood as well. And for the recent 4 to 5 days, I noticed that it's about 3 to 5 teaspoon each time.
Oh, that must be very scaring for you. Did you seek treatment on that? Do you go
No,
to anyway? No. All right. Okay. How okay. Yeah. Apart from the 3 to 4 teaspoons, do you find how it suddenly stop the coughing, the blood? It will
sorry,
stop
again, what was the
before.
question?
What I mean is like after you cough out the blood, any other symptoms that you have experienced?
Oh, symptom. Yeah, doctor, I've been having cough for quite some time as well, almost 2 to 3 weeks already before I have this coughing of blood. So
Mm.
my cough initially was dry. Subsequently, now I'm having a bit of wet cough. But my phlegm is always clear one. It was whitish and then suddenly become bloody. Other than that, doctor, I think I'm actually thinning out. I think I lost a very significant amount of weight.
Okay. Exactly how much of the weight that you lost? Do you know of?
I think for the past 6 months, I've been losing about 10 kg already. Oh.
Is it intentional or unintentional?
No. I don't need to lose weight one, but I don't know why my weight is thinner.
So what is your current weight now?
My current weight now is only 48.
48 kilos. All right.
Mm.
That must be distressing for you. That yeah. How's about your appetite?
Yeah, my appetite is also not great. Not eating well nowadays. Cannot really, I have no appetite at all to eat.
Okay, no appetite. Is it like when you see the food you have no appetite, or any like when you swallow? Is it difficult or how?
No. I can swallow. Just that I don't feel like eating.
You don't feel like eating. All right. Okay. Apart from that, you told me you cough already 2 to 3 weeks. Is this the coughing any particular time it get worse, like at the night or how?
No, it occur throughout the day.
Throughout the days. All right. Regarding with regards the any lumps and bumps over your body that you notice of?
No.
No. All right. Any back to the questions that you're coughing out blood. Is it this is the first time that you experience this, or you had some similar episodes with previously?
No. Previously, no. This is something new for me.
Something new for you, yeah. Okay. Anyone's on? May I know any recent travel history?
No.
No. Or any encounter? Any in your knowledge? Do you
Sorry.
encounter any?
You are saying do I travel recently, right?
Yes.
Yeah, doctor, I'm a businessman, you see. So I frequently travel one. So last I just came back from Paris. It was about 14 hours of flight. It was like almost 3 weeks ago.
Okay. Is it the symptoms that you notice is worsening after your flight?
Not worsening, started actually. I
It
never have any
started.
symptom. Yeah. I think I got some flu there. Lah.
You had the flu there. Okay. Do you take any medication for your flu or anything?
No.
No. How's the flu? Any blood or anything that you notice from your flu?
No. I mean, after I came back to Malaysia, I started to
Hmm.
have this cough. Lah. But I don't have any blood until recently.
All right. Okay. So but the loss of it's already more than six months beyond before that.
Yeah.
All right. Did you seek any medical advice on because of that issue before this?
No.
No. All right. Okay. I just there's a few questions more I need to ask you.
Mm.
You say you traveled 14 hours. Any leg swelling or any legs that you noticed recently?
I did feel my leg is a bit pain that time, but actually now I can walk. I don't feel much issue lah. Swelling wise, I'm not very sure.
Not really sure. Yeah. Anyone else? I mean, they noticed that your lower limb, your legs is more swollen compared to another one, like asymmetrically, not sure anything.
No.
No, all right. Mr. Paul, there's a few questions that I need to ask you to before I guiding me for further investigation. Yeah. All right. Regarding, do you feel any chest pain?
Chest pain, no.
No chest pain. Do you feel any like your heartbeat is racing or anything?
Yeah. I feel sometimes my heart rate is a bit fast, and even when we're resting, also I feel it's getting it's faster than usual.
Correct. How about this 1 week? Do you feel like you're very tired, or any like you feel like you cannot continue work? Anything?
Yeah, tired lah,
No.
doctor. Cannot do stuff already, now.
It's all day.
Yeah, only for the after I come back from Paris, something is wrong in Paris. I don't know.
All right. Okay. Um, any change in your bowel habits for the past 6 months? Like any how's your bowel motion every that worrying you?
No. I mean, my motion was normal, was regular. Every day I also pass out motion.
How many times per day?
Oh, only once.
Only once. Is how's the consistency?
Consistency, you mean is it soft?
Yes,
Yeah, it's soft.
yeah. It's of any blood streak or anything that you notice of?
No.
No, yeah. So before 6 months ago, also the bowel opening also same.
Yeah, same.
All right, okay. Do you notice any rashes over your body, like on whitish color or any blackish rashes or anything?
I notice my hand, especially my fingers and also my feet. Sometimes it actually become red one. I don't know why.
It comes right. When can you tell me exactly more on this? Like on
Yeah,
any particular time?
currently I'm not having this, but I'm not sure. It comes and goes. Sometimes I realize that my hand actually become red. I mean, I don't know whether is it like flushing of my hand as well as my feet. And I notice this actually, especially in the hot weather as well. I tend to have that.
I see. All right. Mr. Paul, okay, can I examine you now?
Yeah, sure. What do you want to
Okay.
examine?
I would like to check the eyes.
Eyes that you want to check for?
Is there any conjunctiva pallor or jaundice?
Your eye actually, the eye actually a bit suffused. There's like redness when you look in detail.
Okay, okay. Can I recheck back the vital signs, the SpO2, because was low at outside,
Yeah, the
98%.
SpO2 is 91 to 92%.
What's the respiratory rate?
He is tachypnic. The RR examiner tell you is about 20.
And heart rate?
Heart rate is 110.
110. All right. Okay. I will proceed to check the cervical and any lymph node or any or swelling that I need to know of.
Okay, so you palpate the neck to look for
Neck,
any
yeah.
lymph nodes.
Lymph nodes, yes.
No palpable cervical lymph nodes.
Okay. Any neck swelling like goiter or anything?
Neck swelling, no.
No. And can I check the hands? Any clubbing? Any peripheral cyanosis?
There's no peripheral cyanosis, no clubbing.
Okay. Any palmar erythema and any guttering of the dorsum of the hands of the muscles?
No guttering, no wasting. But when you check for palmar erythema, you realize that the hand, especially up to the wrist from the finger, actually slightly red. It's non-tender, no, not
Okay.
swollen also. It's just red.
Red. Or any Raynaud's phenomenons that can notice?
As you feel for the hand to press on it and then make it cold, no, there's no change in terms of color.
Any swelling or anything like rheumatoid arthritis changes?
No, there's no joint pain as you feel the hand in brief.
Okay. So I would like to check any finger flapping
No,
tremors? No.
no.
Okay. How about the any on surface any temporal wasting, temporal muscle wasting?
No temporal muscle wasting, but you realize that patient is thin.
Since okay. I proceed to the check on over the lungs. So I would like to check inspection on the chest.
Mm.
Is there any how's the chest expansion? Yeah, any scar or any rashes seen?
No scar, no rash.
All right. How about then I proceed with the percussion and check in is there any dullness in
So
each
percussion
particular
is normal for both sides of the lung. And then on auscultation, the lung breath sound is equal. And then it's vesicular breath sound. You don't find any bronchial breathing. And
how,
yeah,
how about the trachea?
trachea is central.
Trachea central. All right. Then I would like to check for CVS any murmurs or any loud P2.
No murmurs, no loud P2.
Then proceed with the abdomen examination. Is there any hepatosplenomegaly?
No hepatosplenomegaly.
Is there any dilated chest vein, dilated vein that noted?
Over the tummy, abdomen.
Over the
No,
tummy? Yes. No.
no.
Okay. We're to check the lower limb. Is there any the calf tendon? When are there any calf tendon or swelling?
Examiner tell you no calf tenderness.
No calf tenderness. All right. Okay. Uh, okay. So, Mr. Paul, may I know what's your concern? Yeah. Mr. Paul, before I proceed, I just want to ask what is the past medication, past medical history that you have? I need
No,
to
no,
know
no.
of.
I'm very healthy. I don't have any medical problem in the past. I'm not taking any medication also.
Not any surgery done before?
Sorry?
Any, any surgery done before?
Oh, surgery. No, no.
No surgery, yeah. Okay. And you told that you work as a businessman, right? You have been traveled all over the countries. Before you fly to any country, did you complete your vaccination or anything?
Yeah, yeah, yeah. I took all the vaccine already. One.
Took already vaccine already. Okay, good.
2 minutes
Okay.
left.
Yeah. Okay. Mr. Paul, may I know what is your concern? Yeah.
Doctor, what am I having?
Okay, Mr. Paul, based on your examination, and based on the history and examination that I've done thoroughly, I worry that I have no the news is not so good for you because your vital signs also not your oxygen level and your heart rate is very fast. So I would like to get you admitted and for further investigation. Are you okay with that?
Yeah, but what am I having, doctor?
All right. Okay. Based on the history and whatever the informations that you give me, I would like to exclude the possibility of any blood clots in your lungs. Yeah, because of
Because
the reason, yes, because of a recent flight, the long flight that you took, then precipitating this current issue. But another concern for me also, I would like to exclude possibility of the any cancer because that you told me that you have experienced a loss of weight for past 6 months.
oh no, what kind of cancer, doctor?
Okay, Mr. Paul, for now, I still have not much of details on that. But I need to get you admitted and done further investigation, imaging, and also blood tests. Are you okay with that?
Yeah. Do is it possible I have TB? I travel so frequently.
Yes, that's one of the top of my list, but I need to check further some with your sputums and send for the lab testing. Then I will and also X-ray that to see and also the any need for bronchoscopy later on. Yeah,
Oh, okay.
to
Is it
ascertain the
curable,
environment.
doctor?
Yes, for the if let's say it's infection,
Okay, time's
definitely
up, time's
is
up, time's up. Okay, Dr. Chong, can you talk to me regarding differential diagnosis and your provisional diagnosis?
Okay, the first of the diagnosis I would think is this is primary embolism. On top of that, there's possible malignancy.
Oh,
Another
okay.
second will be primary tuberculosis.
Mm-hmm.
Another thing, the third one will be under my list is bronchiectasis. And
Bronchiectasis. Any
yes,
differential? Any other
uh,
differential? You a
w- uh,
significant weight loss i-
vasculitis.
in the middle age group?
Um, middle age group. But I was I think it's vasculitis. Or,
Okay.
mm,
Let's say I tell you the patient is smoking heavily, in which you didn't
lung,
ask.
lung,
What would be
yeah,
your differential?
yeah, lung CA, lung cancer.
Yeah. Okay. All right. How will you how will you investigate this patient?
Okay, I would like to these patients I would actually in the setting of ED I would like to stabilize the airway first and I will apply oxygen. I also check ABG. The
Mm-hmm.
ABG is on because of the SpO2 is 92 to 93 and also he's on tachypneic. So I would like to check what was the ABG that time. Then full blood count to check the hemoglobin level and also straight away GXM because in view of very often anemia and also because she does have anemic symptoms and need transfuse and then check for renal profile, basal renal profile, liver function test and so coact profile. Yeah, and then to get imaging chest X-ray and ECG. Yeah, and also D-dimer.
Okay.
Mm.
And how to confirm your diagnosis?
Okay. From the chest X-ray, I will check. I will determine that whether there is a mass or any consolidating changes that are suggestive of an current infection or TB changes.
Mm-hmm. But how will you confirm other differential? I mean, to exclude and confirm other differential diagnosis. You have mentioned your first diagnosis was pulmonary embolism, right? How would you
Yeah. I
confirm
mean
that?
that one is an need to do a CTPA.
Do you need to do
Mm.
for every patient?
No. Because this patient has the risk, so I will proceed with CTPA.
I
Regardless
see.
of the D-dimer level.
What was the risk that you're mentioning? Is there any scoring
Okay.
system?
The Wells criteria, Wells score.
Yeah. Okay. All right. So you have mentioned CTPA. Okay.
Mm.
And then, is there any specific test you want to order?
D-dimer.
Let's say I tell you that this patient actually have mild splenomegaly.
Mouse splenomegaly. Okay. So,
With regards to him having this hand redness, and when you examine the eye, you notice the eye is a bit red.
all right. So it's an need to check the Jack tool whether this is an yeah.
Okay, you want to check for the JAK2 mutation, right?
Mutation, yes.
Any other tests you want to do?
Um, of course, if let's say suspected essential thrombocytosis of BRV, then BMAT is the gold standard diagnosis. BMAT.
Mm. So, and also your full blood count, you should mention you want to check for
Yeah.
the rates.
MCV.
Yeah. Okay. Okay. All right. How will you manage this patient?
So again, this patient needs to stabilize EVCA airway, breathing and circulation, stabilization and admit, and to discuss a further investigation based on the discuss a further management based on the investigation I mentioned just now.
Okay. Let's say acute setting settled, and let's say there is pulmonary embolism.
Mm.
What other management you want to do?
And advise this patient on anticoagulation, and also need to advise on not for airplane travel, or long distance travel, and also need to settle the underlying issue first, like maybe is the if
Okay.
PRV, then yeah, need to treat that first.
And what would be the treatment?
Um, if let's say this is a polycythemia rubra vera, then there is you have to cycle hydroxy. One of the treatment will be hydroxyurea. Then
Mhm.
some of another if in resistant case, they might need biologic treatment on that.
Okay. Let's say the blood pressure in the ward patient actually have hypotension. What can you offer?
So this is would be the massive pulmonary embolism. So can of if there's an IR services, I would like to do the thrombectomy,
Mm. Okay.
mechanical thrombectomy.
Or even thrombolysis, not necessarily thrombectomy.
Thrombolysis, yeah, yeah,
Okay. Time's up.
thrombolysis.
Okay. Time's up. Okay. How will you feel?
Already
Okay.
palpitation.
Yeah,
Sorry, I
palpitation. I
nervous
can feel
because
you are
my
very nervous. Is it the first time you're doing new format?
yeah. So far as before this, I'm still practicing the OBCC station 8 minutes.
So
So
you
far,
realize the major difference is the OBCC you don't have time to ask a lot of questions, right?
yes,
So time is never a luxury, and then so you also don't have to examine the patient so much, and
yes,
then you also don't have to think a lot of things, especially during the Viva session. But you
yes,
realize that in the new format you had to talk a bit more and tell your ideas and also diagnosis a bit more.
yes.
And yeah, I I think you want to say something, right? Yeah, you say first.
And it's quite challenging because the symptoms itself is already so many differential. So it's like
Mm,
one symptom, but it's like the differential can be a lot. So I need to explore a lot
mm.
of the yeah.
So actually, there's a few things that maybe I think the reason why you feel palpitation and also uh, very nervous is because your approach is not very structured yet in your brain.
Okay.
So let's say you're talking
Mm,
about this is back to the scenario. This is a
mm,
scenario hemoptysis, right? Back to the chief
yes.
complaint. 1 week
Correct.
hemoptysis, right? This
Mm,
is outside the scenario. So you
yes.
need to tell yourself that you have to list out all your differential diagnoses. So this will include definitely acute hemolysis on the rule of PE. First
Mm,
PE, second lung
mm,
cancer, third can be bronchiectasis,
mm,
and TB or
mm,
those things. But you need to branch to exclude everything first, and then you have to commit which one of that is the main issue. And then subsequently, you found out that the patient has a long weight loss. I
mm,
offer the weight loss very early is try to
yes.
confuse you. Then you will realize that okay, you are dealing with acute and chronic issue already.
Yeah,
So
correct.
it's a bit complicated. So now you need to decide because weight loss is always infection or malignancy. So you
Mm,
have to decide which is the one.
yes.
So you have to really go very targeted. But please you have to complete the HOPI first, and then if you want to ask about PE, right, you should ask the full set of PE question. Cannot be just one or two question. So in the sense of
Okay.
PE, you should
Mm,
ask about straight away. You should ask about any. Yeah, you ask traveling history very early. I would say very good. You managed to get that patient have a long haul flight, and then you should ask about any surgery done. But you ask in the last lah, quite
okay.
far. And then you also ask about infection. But for PE, yeah, for
Mm,
anyone like male and female, for
mm,
everyone that is actually more than 50 years old, we need to exclude malignancy, lah, no?
mm,
So you have to ask screen for malignancy question. Other than weight loss, things like that, you have to ask a bit more.
mm,
Like lung cancer, therefore you can ask the smoking history early. It's okay to ask early for this case.
Okay.
And then if you're talking about prostate cancer, then yes, you have to ask whether there's any difficulty to pass urine. And if you're talking about any bone cancer, you should ask about any bone pain. You're talking about any other cancer, for example, lymphoma, lumps and bumps, you already asked that. So cancer, you are covered. The next is actually the hematological malignancy. In which you can ask whether any tummy discomfort. You did ask. There's no tummy discomfort. And then you should also ask about uh PRV, which is one of the commonest exam question, not in real life, but in exam it can be quite common because of prothrombotic condition. So you should ask very targeted question. You should ask patient whether patient have any itchiness after the hot shower, aquagenic pruritus. You should ask straight away this question to screen for PRV, and then you should ask whether there's any redness over your eyes, any redness over your hands or feet. If you ask this early, then you got a diagnosis. But this is not enough. Sometimes the PE risk factor can also occur in those younger age group, although they manifest later. So you should also ask about PNH. You should ask about any episodic passing of dark color urine when you wake up in the morning to suggest proximal nocturnal hemoglobinuria. You should also ask about any soreness over the lips and also the eyes and also the private area to suggest Behçet's disease. Yes, you asked about IBD. I can see that you try to exclude any bloody stool and no any change in stool, and you in a way try to screen for nephrotic as well because you asked about leg swelling in particularly. Although I know you're trying to do RDVT, and
Yeah.
you should also ask any swelling over the face as well, lah. Not just the limbs. And you should also ask about any family history. This scenario didn't ask anything about family history. You should any family history of blood disorder, any family history of no
Yeah.
any previous history of blood clot before. You should ask the patient that. And then for female, then you have to add on a few more questions, which is one of them is commonest is APLS. Ask about autoimmune symptom, abortion, hair loss, skin rash, joint pain, like that. And then pregnancy also. So those are the additional questions. But generally, you need to be very focused when you want to exclude PE. So if you don't think it's PE, if everything else is negative, then the next question is actually your lung cancer. So you should really ask the smoking history early. You should really ask patient smoke and then any family history of cancer. Okay.
Okay.
Then
Yeah.
the
Actually,
next
I highlighted it, but I forgot to ask.
yeah, because your thought process is already already messed up because it's too a lot of things happening at the same time and there's a acute issue and a chronic issue. Oh.
Yeah.
And then another thing is actually if you talk about bronchiectasis, you should ask any lung condition in the past. Bronchiectasis cannot be just occur out of nowhere. It might have some lung problem in the past. And then here comes the occupation important. So patient is a businessman. You must ask actually patient have any contact with any heavy metal, any dust or anything that predispose patient to have ILD, like you say, or even bronchiectasis. And then probably the last one is the vasculitis part, which I think you also asked about all those things. But you need to go by the level of diagnosis. First is actually you're talking about acute hemolysis. You need to establish hemolysis first. Then what causes the hemolysis? If it's PE, then yes, it's cancer. But what cancer? You need to ask yourself this. So you need to really screen through the question quite fast. I think you are quite draggy in beginning. You almost use about 2 minutes in the initial part when you try to elicit the HOPI because you use about 1 minute to convert 90. Actually, it's a waste of time to do that. Just mention that. May I confirm that I'm Dr. Cheong. I'm one of the doctor in the emergency department. May I confirm that this is you are Mr. Paul, 65 years old?
Okay.
Just like that. And then I was going to take some notes and examine you. You say, okay, yes, okay. I'm been told that you have this coughing and blood. Would you mind to tell me more? Just like that. I mean, just three sentences to open up the whole thing, just to save time. Yeah.
Okay.
Because you can see that even with 12 minutes of history and examination, you also don't have time to finish your history.
Yes.
Okay. All right. Okay. So this is just some. I mean, you got most of the thing. Like the idea for this patient is to exclude other prothrombotic condition, and to actually, if you don't ask about specific question, I decided to give you this hand redness. And prothrombotic condition is one by one you have to exclude, in which you exclude a few. And then, yes, traveling in this history is important. Remember, in any scenario we suspect for PE, we should always screen for traveling history and surgical. Okay, so examination wise is about yes, you want to check for any suffusion, erythromelalgia, and lungs. Yes, you have mentioned it correctly, which I didn't put in my calibration. It's actually abdomen. Must really check for any hepatosplenomegaly. You mentioned that actually, but I decided not to give because I want to see whether you will think about it or not, even without knowing that patient.
I couldn't because I was like all look like normal except for red over the hands. I was like, okay, I don't know what is this really.
But you know that something is missing in your diagnosis, right?
Yes.
Yeah. Okay. Another thing, yes, you're good. You check for leg calf tenderness and also fullness. And also you notice that the SpO2 is already low. And patient is tachycardic. So this is all, I mean, the vital sign per se in their calibration already can consider 1 mark. So vital sign is important. And that differential diagnosis, PE, lung cancer, TB, and also bronchiectasis or ILD can. And what do I have? You mentioned that TB possible, condition curable. Actually, this one we don't know. And the management of PRV, I just want to recap back. What is your management? You have mentioned straight to hydroxyurea
It
with
depends
PRV
on
biologic.
it depends on the stage of the PRV that whether
There's only
the
two
patient
stage.
symptom. Yeah.
There's only two stage. So it's either high risk or low risk patient.
Yeah. Mm.
So a patient that more than 50 years old or have evidence of thrombosis, be it a venous or arterial thrombosis, that itself classified as high risk.
Mm.
For low risk, what will you give? What you do? I mean, what was the management for low risk?
Can mini section, regular mini section.
Okay, PRM section. Other than that,
Um,
so essentially there's only three things for low risk. First thing is actually always talk about modify and reduce the cardiovascular risk because they have higher risk to develop stroke, MI, and also ischemic heart disease. So cardiovascular risk management should be mentioned. Second thing is the background.
sorry.
No problem. So the second thing is actually you mentioned that section PRN as per needed. The third thing you need to mention is the prevention of the stroke, which is the aspirin. That's why we routinely start patient with aspirin for low risk patient.
Yeah.
Okay, so cardiovascular risk modification, aspirin, and section. For high risk patient, it's same as low risk, but you need to add hydroxy urea, which is cytoreductive agent. So we got a few cytoreductive agent. So the only thing that differentiate management between low risk and high risk is the addition of the cytoreductive agent. So cytoreductive agent have first line is hydroxyurea, yes. Second line we have interferon. We also have busulfane. We also have danazol. I think like what you mentioned, the biologics, luxonitinib is also another one. Okay, so that will be the management for the PRV. But I think in terms of when you talk about investigation and management for PE per se, you should mention early that I will need to uh, carry out a few blood tests, including fetal count, coagulation profile, D-dimer. And you may not want to mention D-dimer straight. You may want to say that and also calculate two-level well score. If the well score is more than 6, then I will proceed with CTPA. If the well score is less than 6, I will proceed with D-dimer. And if it's high, then proceed with CTPA. If the well score is less than 6, D-dimer is low, but my clinical suspicion is still high, I will really need to discuss with my consultant and maybe still need to consider to do an ultrasound Doppler of the lower limb at least. You can mention like that. And then yes, management acute and long term. Acute management, you should mention that whether patient is hemodynamic stable. Hemodynamic stable can start patient anticoagulation, DOAC, warfarin, or even temporary with taxane, low mercury heparin, therapeutic dose. However, if hemodynamic unstable, then I should consider to give thrombolysis or thrombectomy depending on the facilities. You should just mention like that.
Okay.
So that will be it. And if the additional question examiner can ask you is how long the treatment for this PE will need.
Okay.
So how long will you give this PE treatment?
In his case, the if is PRV with JAK2 positive will be lifelong.
Most likely will need lifelong, right? So the full diagnosis for this patient actually, yes, is provoked by long haul flight, but long haul flight cannot be just the triggered lah. Usually, if the exam really come out like that and the cost is really like very very low, I mean very, very low probability, like just long haul flight, then really you must really look for something else.
Okay.
Okay. So anything else you want to ask me? Any question for anyone?
I don't have, but I think I need to practice more lah, that's all.
So I think your problem is I think your knowledge is there, your flow is there. Just that you are being disturbed because whenever something new information come in, you will be very nervous because you lost the direction. You must complete the history for hemolysis first, then only you do one by one. You go in another level. So there's something that I learned from the Singapore, one of the Singapore uh I don't know whether he's examiner now, but he was a tutor before. So he mentioned that he always have difficulty when he prepare PACES, especially for BCC, for O format, because he have difficulty to go too deep for one diagnosis, for one differential diagnosis. At the same time, he need to exclude and cover all differential diagnosis. So he always mentioned that if you are imagining yourself, if you're walking to an apartment, you are going to level, or you're going to at each level you're going to the room and room. So it's all floor and also the room. So you have to decide yourself which one is more important. You cannot be asking everything too detailed. At the same time, you cannot miss out asking things that is common to be covered. So for this stem is actually not difficult, but it can be difficult if you lost the approach. So you still need to go through the hemolysis. You just cover the differential diagnosis one by one. At this point of time, cannot exclude lung cancer versus pulmonary embolism, but generally no TB symptom, no lung disease, you already exclude two, right? So now you're left with this lung cancer versus PE. So you start to ask about all the PE question. If the PE question really nothing, then you know that most likely it's not PE lah. And but this patient is different. This patient got hint already, got traveling history, just came back from Paris. Then you know that your PE diagnosis is very, very obvious. So you next is actually to go in depth into the PE part, and you want to exclude one by one the causes of PE. Anyone less than 50 years old, we should really, just like what my notes have mentioned, for male, when you go up PNH, Behçet's disease, IBD, nephrotic syndrome, congenital thrombophilia, and also PRV. Anyone that more than 50 years old, you should also rule out any form of malignancy, cancer-associated thrombosis, CAT, and also at the same time PRV. Female, everything's the same. Just add on APRS as well as the pregnancy or preeclampsia and all those gynecological problems. The rest is the same. Okay?
Okay.
Okay, thank you for taking part. Okay?
Okay, thank you very much.
Okay, thank you. So the next candidate, I think we'll go with Eldon. I managed to find the last replacement, but you'll be the fourth case lah, huh? So Eldon, are you ready? Can you unmute yourself?
Good morning, Jimmy. Can hear?
Ah, can, Eldon. Long time no see.
Yeah.
Okay, so let's try lah. Okay, you're ready, right?
Yeah.
Okay, so I'll give you 5 minutes for the to prepare the scenario, and your time start now. Okay, 5 minutes is up. Dr. Eldon,
Mm.
this is the patient, Mr. Alex. Please start.
Hi, good morning, Mr. Alex. I'm Dr. Eldon here, one of the doctors in the clinic today. I may confirm you are Mr. Alex, you're 45 years old.
Yeah, I'm 45 this year. I'm Alex.
Hi, I received reports that you are experiencing some leg swelling. Can you tell me more about this?
Yeah, doctor, I've been having this leg swelling for the almost 4 months already. This swelling actually initially started. I just feel a sensation of heaviness when I want to walk, and realized that for the past 1 or 2 months, it has been getting worse, and both of my legs is also swollen. And then initially it's just over my toes and also my ankle, and then now it actually start to come out until my leg. I'm very worried, doctor.
Okay, firstly, I'm very sorry that this has happened to you. So hopefully by the end of this consultation, I will be able to get a diagnosis and to able to start some treatment for you. Is that okay?
Yeah, thank you, thank you.
Okay, so may I know more about this swelling? So may I know this started 4 months ago, right?
Yeah.
So does this happen suddenly or does this happen gradually?
I think it's happened gradually.
Okay, is it always there? Does it comes and goes?
It comes and go initially. Then subsequently, for the last 1 month, I realized that it had been becoming persistent and getting worse.
Okay, sure. Um, Other than the leg swelling, do you realize is there any pain during when the swelling had occurred?
No, there's no pain.
Okay, so apart from the legs, do you experience any other parts of the body that experience swelling?
Yeah. I realized that my tummy also getting more swollen as well.
I see. Okay, does this happen at the same time with the legs or which comes first?
Yeah, I think the leg come first. My tummy swollen just about 2 months time.
I see, I see. All right. Is there do you experiencing any weight loss during this period?
No. My appetite, my weight is quite good.
Okay, all right. Any problems with your urination? Do you notice that your urination is more bubbly than usual?
Yeah, I realized that my urine is getting more frothy. Lah.
Okay,
For the
all right.
mm,
Any blood in your urination?
no.
Okay. Any pain during your urination?
No.
Okay. Sorry, I mentioned apart from the legs and the tummy is swelling, right? What about your face? Do you notice that your face looks puffy than usual?
Yeah, I realized that especially when I wake up in the morning, my face, the one that I actually, the side that I lie on my pillow is actually usually more swollen compared to the other side. But
Mm,
generally, after some time, it will reduce.
okay. All right. All right. So Mr. Alex, do you experiencing other problems apart from this? Do you have other concerns that about this swelling? Any other symptoms that you're experiencing as well?
Yeah, doctor. I am very shy to tell you, but I also have a lot of swelling over my private area.
Okay. Does it happen during the same time or does it happen separately?
Yeah, almost the same time.
Okay, all right. I noticed that this is very, very distressing for you, all right? So don't worry, we'll try to help you, okay? Uh,
Yeah.
what about when you sleep, do you use more than one pillow when you sleep?
No. Just one pillow enough for me.
Okay. Do you wake up in the middle of the night you feeling breathless?
No.
Okay. So apart from this swelling, do you notice during your everyday life, do you feel more breathless than usual? Like your exercise tolerance is reduced?
Yeah, definitely reduce, I feel, because first is my leg, I feel very heavy to move.
Mm,
Second is when I walk a long distance, I tend to feel breathless also.
Okay, all right. Any coughs, unusual coughs?
No.
Any vomiting or any diarrhea, loose stools?
No loose too.
Okay. You mentioned no abdominal pain, right?
Hmm.
Okay. Any rashes that you're experiencing during this period?
No.
Any joint pains?
No.
Do you notice any unusual hair loss?
No.
Any ulcers or wounds in the mouth?
No.
Okay, sure. Any headaches occurring during this period, or any giddiness?
Headache, no. Giddiness also, no.
Okay. Any blurring of having difficulty in your vision?
No.
Okay, so I will have to ask you for some further questions. Is that okay?
Yeah, sure.
All right, sure. Do you have any previous medical history, like and were you admitted since young for any unusual cause?
Yeah, doctor, I have been having diabetes for very long, and I also have high blood pressure. I have these two medical condition.
Okay, can I know how long you have been with the diabetes and
Diabetes
hypertension?
almost 10 years already.
I see. And the hypertension as well?
Hypertension is about 5 years.
Okay, all right. Are you taking any medication or are you any follow-up?
Yeah, I'm seeing under the Clinic Kesihatan. So I'm only on two medication for
Mm-hmm.
my diabetes. One is a metformin, I think 2 tablets twice per day.
Mm.
Second one is the gliclazide, it's a MR, I think modified release, 60
Okay,
mg once a day.
okay,
And for my high blood pressure, I'm taking amlodipine 5 mg OD.
okay, sure. Any insulin you're using, injections?
No.
Okay. Any history of any operations done before?
No.
Okay. So, I'll ask regarding your family. Anyone in your family, I mean your siblings, your parents, anyone having this leg problem, like swelling, or having diabetes or high blood pressure?
Yeah. My mother and father also have high blood pressure,
Mm.
but three of my siblings actually also have diabetes.
Oh, okay. All right. Sure. Very strong family history. Yeah.
Mm.
Okay. So sorry. Going back to your symptoms, I missed out something. Do you experience any loss of weight?
No, you ask me.
Okay. All right. Sure.
I gain
Uh.
from
mm,
my weight. I have some weight gain because of this. I think a lot of
okay.
water in my body.
Okay. Sure. Are you taking any supplements as well? Any traditional medication?
Yeah. Unfortunately, if you ask, I've been taking these Chinese herbs for
Mm,
almost 6 months now. The
mm,
reason I take is because I was told by my friend that diabetes patient need to reduce the sugar level, and this Chinese herb can actually help to reduce the sugar level.
I see. I see. Okay. Um. Okay. So, Mr. Alex, I was asking, are you a smoker?
Yeah. I do smoke occasionally, but generally it's because I work with my business partner. When we go for business trip, we have to smoke, and then for social issue lah. But I don't usually smoke. Maybe 1 week about once or twice only.
Okay. Sure. What alcohol? Do you drink alcohol?
No, I don't drink alcohol.
Okay, sure. Thanks. Do you have any allergies before?
No, no allergy.
Okay. What about traveling? Do you frequently travel? Do you recently travel to a certain parts of the for
Uh,
your
in Malaysia, yes, I do travel across the state just to for
Hmm.
business reason, but
Hmm.
I seldom go out from to overseas.
Okay, sure. Sorry to ask some personal questions. Are you married?
Yeah, yeah, I'm staying with my wife. We have one children.
Okay, sure. Do you experience any difficulty during your sexual life? Any problems?
As you can see, for the past 4 months now, my private area is so swollen. I'm very shy. My wife also don't like it. We cannot really have any intimate relationship anymore.
I see, I see. I'm so sorry to hear that. Okay. Mr. Alex, do you do mind if I proceed to check on you?
Yeah, yeah.
Okay, so I'd like to look at the general appearance of the patient. Is
Mm.
he edematous or how's the general appearance?
General appearance, there is a bit of periorbital edema. And
Mm-hmm.
then generally you can see that the leg actually got swelling bilaterally.
Mm. May I know the swelling? So I press the swelling. Is it pitting or non-pitting?
Yeah, it's pitting.
Pitting. Okay. What about? I check the hands. Is there any evidence of leukonychia or any pulmonary erythema? Any signs of chronic liver disease?
No leukonychia, no pulmonary erythema, no
Any
class.
any flaps to suggest uremia or hepatic flaps?
When you ask patient to do a flap, there's no flap.
Okay. No scratch marks over the arms.
Yeah, there's also no scratch mark.
Any pallor or any jaundice?
No pallor, no jaundice.
Okay. Moving on to the neck, is there any elevated JVP?
Yeah, JP is elevated.
Okay. Any lymph nodes palpable?
No palpable lymph nodes.
Okay. Any neck swelling? Any thyroid swelling?
No direct swelling.
Okay. Moving on to the chest, I just want to hear the lungs. Is there any crepitations heard?
Yeah, there is bibasal crepitation.
Okay. Any displaced apex beat?
Apex beat is the same for you. It's
Any
normal. Sorry, any
any
murmur?
Hmm.
No murmur.
No murmur. Okay. Moving on to the abdomen, is there any evidence of ascites?
So you are checking for shifting
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 downwards,
downwards.
split through and shifting downwards.
Okay, so when you check for shifting downwards is positive, examiner say you no need to proceed with free trial.
Okay. Is there any presence of hepatomegaly or splenomegaly?
No hepato or splenomegaly.
Okay. Is there blottable kidneys to suggest polycystic kidney?
Good. No palatable kidneys.
Okay. Is there evidence of sacral edema?
There is sacral edema.
Okay. All right. So I would like to examine the genitals for how to assess how bad is the scrotal swelling or any
Yeah.
penile swelling.
Good. You have found he has a scrotal edema, quite huge.
Okay. All right. Moving on back to the history, I missed out something. Do you have any any tremors of the hands, or do you feel you cannot stand any cold weather or especially hot weathers?
No.
Okay. Any difficulty in your passing motion, any diarrheas or any constipation?
No. My bowel motion has been quite okay.
Okay, sure. Thank you. So moving on to the examination again. Just check if any clubbing, finger clubbing or not.
No, no clubbing.
Okay. Is there any what is that? Any signs of acanthosis nigricans, any diabetic dermopathy?
So the over his leg, although there's no photo here, there's a bit of diabetic dermopathy. There's a bit of hyperpigmentation over the shin,
So
but
like
no acanthosis nigricans.
okay, just do a quick neurological examination. Is there any neuropathy associated, like any do the filament test? Is there any signs of microvascular complications such as neuropathy?
So when you check for the neuropathy, you use a pinprick, right, of filament. There's no peripheral neuropathy.
Okay, all right. So Mr. Alex, so may I know what is your concern? What you're particularly worried about?
Yeah, doctor, why my legs are swollen? What is the cause of this?
Okay, so Mr. Alex, so there are a few causes that can actually contribute to your condition. So number one, I like to think of would be a kidney problem, which has led to increased protein excretion through your urine, which has resulted in we call it something called nephrotic syndrome. You don't mind this term. So this is basically a condition where due to your long-standing diabetes and hypertension, which I think most likely has resulted in your prolonged kidney insult, which has led to all these complications such as your leg swellings, your puffy face, and all this because due to the low protein in your blood.
Oh, but what causes this condition to occur?
This is because of the kidneys, because of the long-standing diabetes and the hypertension. It has caused some damage to the part of the small red cells of the kidneys, cause some more leakage. So that when the protein goes out, it leads to some differences in the pressure in your blood. So it will cause this call it the fluid to loss to your other tissues to cause some swelling.
Oh, wow. Seems very, very technical. But can it be due to the medication that I'm taking? My high blood pressure medication, they say also can cause leg swelling.
Yes, this is possible, but however, usually the medication that is called amlodipine is also a possible cause to cause some ankle swelling. But however, in my opinion, because of the usually amlodipine only causes mild swelling over the ankles. But however, in your case, you are experiencing some
2 minutes left.
swelling up to your scrotal and also some facial swelling. So I think the most likely cause would be the protein leakage through your kidneys. However, there are also further tests which I need to confirm again, such as a liver problem and also some heart problem. We will do some further tests again to ascertain and to confirm what's the diagnosis again.
Doctor, you say that it's due to the kidney problem, right? Do I need dialysis?
Don't need. We will do some blood tests first to examine the severity of the kidney problem. We will stage your kidney problems, the disease based on the blood test and the urine test. However, at this point in time, upon examining you, you are not having any we call it emergency need for dialysis at the moment.
I see. Okay. Do I need admission then?
Don't need yet because you're not experiencing any red flag symptoms such as a difficulty in breathing and your blood pressure, all they are stable. So we will do some tests today. We'll do some blood tests, we do some urine tests, we do some x-rays and also some scans of the kidneys to make sure everything is being checked out. And we will see you back early in the clinic, probably in about 1 to 2 weeks time to review all the results. And then we'll let you know what is the confirmed diagnosis.
Oh, how about do I need to continue all my medication that I'm taking now?
For your diabetes or that, we will check also how good is the control of your diabetes and your blood pressure. So based on the information that I've received regarding blood pressure, is actually fairly okay, well controlled. Therefore, I think one of the medication, the amlodipine, I can change it to something else also, just to make sure that it's not due to this problem.
Oh, okay. All right, time's up. Good. Dr. Alden, can you tell me your differential diagnosis and provisional diagnosis for this patient?
So I would think that this patient most likely has a nephrotic syndrome due to a long-standing diabetic nephropathy. My other differentials would be a chronic liver disease as presence of ascites and also there just to rule out any congestive cardiac failure and also just to rule out any hypothyroidism, which also can cause a bilateral low limb swelling.
Hypothyroid. Okay. So but you do not able to elicit any positive history for cardiac and also liver causes, right?
Yes.
Okay. So what would be other causes of nephrotic syndrome for this patient then? Is there any other possibility?
So there is a connective tissue disorder types such as SLE. It can be vasculitis causing.
But for this patient?
For this patient, I did probably could be due to minimal change disease
Because of?
because of a normal blood pressure and just 40 urine without any hematuria.
Mm.
And also it's due from the diabetes and hypertension.
But how will you differentiate this is due to diabetic nephropathy or this is due to something else? Because you from the history you didn't seem to elicit the control of the sugar, right? And you did not assess for the complication for diabetes. Because when you check for peripheral neuropathy, patient have no peripheral neuropathy. So if this is not due to diabetic with end organ damage, what else can the nephrotic syndrome cause in this patient?
It be due to One is a connective tissue disease. The other one could be, I mean, yeah, to really the diagnosis is uncertain, we can do a renal biopsy, but that's the last resort.
Okay, now, Mike, how will you work out for this patient?
So I will do a regular blood test, fecal blood count, renal profile, liver function test, do a urine dipstick or urine FME, do a 24-hour urine protein SUPCI. We'll do a HbA1c and see diabetic control. Also do some further scans such as the ultrasound, KUB, and or Doppler to see how's the kidney function and the kidney size. And also any echo to look at the heart function. And
Okay.
check to see any cardiomegaly or any presence of pleural effusion or pulmonary congestion.
How about working out for the cause of nephrotic syndrome?
Can do autoimmune screening such as the ANA, rheumatoid factors. Can do a thyroid function test as well. Yeah. Can do
Infective causes? Anything that you want to order for infective causes?
Yeah, can do a hepatic screen, HIV, Hep B, Hep C, which also will lead to nephrotic syndrome also.
Okay, all right, sure. So let's say patient, let's say not in this patient, but another possible workup. Let's say patient got a bit of flu-like symptom. Is there anything that you want to order under your investigation for nephrotic?
Can do a ASOT, streptococcal titer.
Okay, all right. How will you manage this patient?
So I would like to do all the above blood tests, urine tests, also some imaging to ascertain the cause of the disease. Then I can start him some diuretics just to relieve the symptoms of the neck swelling. So after once we'll see him back in the clinic early, about 1 to 2 weeks. Then we will see what's the results like. Then we will try to find the cause of it. So in the meantime, his blood pressure medicine, I would like to change to something such as ACE or angiotensin receptor blockers. So it's to help with the protect the kidneys, and also is to help with the diabetes.
I see. Okay. So other than this, you mentioned, is there any, let's say the patient have renal impairment on top of nephrotic syndrome, do you still want to start patient on ACE?
If it depends on how bad is the trend of the kidney problem. If let's say this has been something chronic or long standing, yes, I think the benefits of starting ACE would be better in terms of kidney protection in this case.
Is there any anti-proteurinic agent that you know?
Can be used calcium channel blockers like diltiazem. I think that's all I know.
Okay, time's up. 20 minutes already. Jenny, very good. Very good. I think you almost asked most of the thing and you are quite fast. But the diagnosis, you you know you missed something, right? When I ask you if it's not diabetic, then what else? You already asked that. You got the very important crucial information in the history, but you didn't convey that when you go for diagnosis. What other medication patient took on top of the medication that was prescribed by doctor?
Traditional medication.
Yeah, traditional medication. Medication. Yeah, traditional medication. And this scenario, if I'm you, I will be very anxious in the sense of differentiating whether this is a traditional medication induced nephrotic syndrome or this is diabetic kidney disease. So therefore, it's important for you to really assess the control, compliance, and complication for diabetes. You have to really ask the symptom in the sense that is the patient taking medication, compliance? Yes. Second is the control. You should ask patient, when is the last time patient went for checkup? And then did the doctor tell you what is the sugar control? If to ask HbA1c, easier way is to ask, do the doctor tell you how is the sugar control for the past 3 months? And the next thing is, if the doctor don't have the result, you just ask the patient, do you check your sugar at home? And usually, how is the sugar pattern like? This is to assess control. Compliance, you really need to ask a bit more. I would expect you to really ask the complication, because or else you cannot differentiate whether this is a traditional medication induced or this is due to diabetic kidney disease. So complication, I routinely go through micro and macrovascular. Macrovascular, ask with any history of stroke. Any history of stroke is a common name. You can just say stroke. Any history of stroke, any history of heart attack, or mini stroke or mini heart attack. You want to mention that also, okay? Any history of you have any pains over your leg as you walk along a distance to suggest claudication in peripheral vascular disease, right? Also macrovascular. And the next is a microvascular. Microvascular, any worsening of your vision. Do you have it went for any eye checkup before? And how about in terms of nephropathy, you ask, have you ever checked for your kidney function before? If they told you the kidney function is normal in the past, and then check for urine, also no protein, so-called no protein, and then no fatty urine, and this is something new, then you know that this is unlikely due to diabetic nephropathy per se. And the next thing is if the patient has any numbness over the hands or leg. You didn't ask that, but you examine for that. I think you remember certainly want to examine the diabetic complication.
Yeah.
And the last one, yes, you asked correctly, very important for diabetic patient to ask for any erectile dysfunction. So you, instead of mentioning sexual or activity, things like that, it's easier to ask, do you have any difficulty with erection in the morning? Do you have any difficulty in intimate relationship? You can ask like that, a more gentle way. But I know in UK, they will just ask, do you have any problem with sex? Like that. But it's okay. I mean, for us, we are a bit more conserved. We can always ask that, do you have any issue in intimate relationship? Do you have any difficulty in erection in the morning? You can ask like that. Erectile dysfunction is part of the microvascular, right? And then next is the muffled D, which is also part of the complication for diabetes. You can ask about itchiness, jaundice, in which you did explore when you exclude the differential diagnosis. Generally, this patient, I think you did very well. You excluded a lot of things. And then, yes, but the only thing I want, perhaps you can improve, is to really explore about this. Because remember, for all kidney disease, whether it's nephrotic or nephritic, we really need to make sure this is not HIV or any hepatitis. So therefore, regardless patient married or not, we have to really ask. So the easier way to ask is actually, have you ever practiced any unsafe intimate relationship in the past and for now? You can just ask like that, because patient may be married and may be loyal to the wife, but in the past may have some naughty behavior in the past. We don't know. But depending on how we question the patient, if you question the patient, do you have any extramarital marriage? The patient may say no. Of course, at this point of time, patient is married, there's no extramarital marriage, but who knows before that? So the safer way to ask is actually, do you ever have any unsafe intimate relationship other than with your wife? You can just ask like that, very simple question, and can screen for a lot of things. And then in terms of high risk behavior, instead of just asking about SI, sexual intercourse, you should also ask about any history of illegal drug use, any party drugs, any history of recent blood transfusion, and any tattooing or ear piercing. So usually all these are one set one. If you want to assess high risk behavior, you just ask everything brought together. But before that, you prompt the patient saying that, I'm sorry to ask, I got a few sensitive questions. It's important for me to make sure that it's not due to all these conditions. Then you ask about all that. Okay. Other than that, your history is really good already, very good already. And you manage to get this thing that I expect that some of us may actually miss. Even in exam, in a highly stressful situation, you get carried away by the medication and the dose and the compliance complication. Then suddenly you didn't ask about any other medication. Okay? So I think you did good. Just that you didn't convey this Chinese back to your diagnosis, or else you will already score full marks. And then, yes, examination, you did good. I would calibrate the scrotal edema to be part of the mark because this is something significant and disturbing the patient. You really need to make sure that the scrotal edema is not infected or discharged or anything. But generally in exam, we just have a look, just say, sorry, can I have a look at the prior area to make sure there's no infection. Just a showmanship. Just open up, okay, close, settle. No need to touch also. But this is just a showmanship, which I feel it will show that we are empathy. One of the things that show empathy is to address back what is the main problem that the patient has. So part of it is to answer the question under the concern. And second of it is actually throughout the conversation, throughout the short history and interaction with the surrogate or patient, what is their daily activity limitation that sometimes they may not convey under the question concern. So like, for example, you ask about any issue in your activities, in your daily living, then the patient actually convey that cannot really have any intimate relationship anymore. All these things is very distressing. So you know that this is, although it's not written formally as a concern, but this is also something that is quite important for us to address, in which you did very good. And yes, generally for this case, it's more to nephrotic syndrome, and there's no evidence of heart failure or any chronic liver disease. And this case, another issue to ask about high risk behavior also, because you have to exclude liver disease. And to exclude liver disease, you also need to explore high risk behavior. So might as well just ask high risk behavior.
Okay.
And the workup diagnosis and management, I think is quite okay. Just that the anti-proteinuria agent, now I mean this is just something our exam, or maybe can be asked in exam also. For diabetic kidney disease in particular, nowadays we have 4 pillars of diabetic kidney disease already. In heart failure, we always talk about 4 pillars or 5 pillars, right? But for diabetic kidney disease, nowadays we have 4 pillars already. You know what are the 4 pillars? ACE and ARB is one of them, correct? Any other pillars? You mentioned calcium channel blocker, right?
Buddhism.
Yeah, the Buddhism actually, in fact, I mean for most of the hospital that don't have the better medication, yes, Buddhism works. But do you know of any new medication under calcium channel blocker?
Not really sure.
So there's this thing called nicanidipine. Heard about it before?
Not using.
Yeah. So nicanidipine is something new, but something will be out in market after. If let's say there's a generic medication soon, I don't know, maybe in next 1 or 2 years, then this medication is going to be very popular and very famous because it's proven to reduce. This is the only calcium channel blocker that is proven to reduce protein in the urine, to reduce proteinuria. At the same time, also reduce the blood pressure. And compared to Dutaism are more centrally acting, are more targeting on the heart arrhythmia, but there is also mild form of anti-proteinuria effect. So in the exam, if let's say you really, I mean, if the examiner is cardiologist that asking you this question, I'm sure he's going to ask you this question. Okay? Cardiologists always go by evidence one. So nicanidipine is also one of the pillars which is under the calcium channel blocker. Is there any pillars that you know?
For what kind heart is it?
For diabetic kidney disease?
Diabetic kidney, can use the SGLT2.
Yeah, interesting. You are right. SGLT can reduce the kidney and also the diabetic, right? Can optimize both. That's the last medication that you can use, which also shows to improve the diabetic control as well as cardiovascular risk. And under the cardiovascular risk, secondary endpoint is the kidney. Injectable form.
Glutides, is it the
Yeah, GLP-1.
GLP-1, huh?
Yeah, GLP-1 inhibitor, the semaglutide, liraglutide. So these are the 4 pillars of diabetic kidney disease. So in heart failure, we know that the 4 pillars or 5 pillars is the ACE, ARB, ARNI as one of the pillars. Second is beta blocker. Third is MRA. Fourth is SGLT2, right? And for diabetic kidney disease, we now have 4 pillars. So if this scenario is a diabetic kidney disease, which can be possible to come on exam, very common, they like to test like autonomic neuropathy, secondary to diabetes, diabetic kidney disease. They like to try all these kind of simple diagnosis, but they expect a lot of things. So if they ask about diabetic kidney disease, you should measure about these 4 pillars. So it's something that can help you to boost out your confidence as well as the evidence-based management in terms of pharmacological. But non-pharmacological, for this patient, you also need to mention you also need to mention about fluid restriction. Very important, right? Very simple, but yet
Those for diet.
most of the time you'll forget to mention that in the exam. Fluid restriction, and then also have to avoid nowadays there are 2 different schools of thought, but generally for nephrotic syndrome, we should not give high protein diet. Okay, we should not give high protein diet generally. I know as the patient become end stage, then yes, you have to give high protein diet. There's no other protein source. But generally, we should reduce the protein damage to the GLOM. And I think most of the discussion already been done. I think you're quite okay. Actually, I think if your flow are very smooth, your timing is very good, and I think you have not much issue. The only issue is maybe you have to take a step back and think a bit when you prepare for the discussion. You're very good already.
Let's say I didn't get the straight point of this traditional medication nephropathy. Will I fail the station or what?
Depends on the examiner. If they recalibrated the scenario, the provisional diagnosis is nephrotic syndrome secondary to traditional medication. And if you give diabetic nephropathy as a differential, but you did not mention traditional medication in your differential diagnosis at all, let's say didn't mention anything at all, most of the time examiner will give you half mark because your diagnosis partially correct. It's still nephrotic syndrome, but the cause you didn't manage to explore. But some very strict examiner, they will try to do is they will give you hint. If they give you hint and you cannot get the traditional medication thingy and they think it's important, they may not give you mark for the differential analysis. But that doesn't mean that they will not give you mark for the other thing like clinical judgment, things like that. Because to me, it's important to know this because your management is to stop traditional medication. Because if you didn't get that part of history, your clinical judgment is partially correct only. It's not fully correct. You did not reverse the cause, right? So that's why a strict examiner may only give you half mark for clinical judgment and differential diagnosis. But a good examiner, I tell you, they will give you marks also. But they will hint you, how about traditional medication? Do you think the patient need to stop? And if you say yes, okay, full marks. So it really depends on your luck sometimes. But from our side, as part of our role as a candidate, to me, it still need to be aiming for perfection. Just try our best and make sure we didn't miss anything. And so that you can see your discussion is very smooth. You go for investigation and management, you didn't have any much issue in terms of conveying your idea. So I think that's good. The only way start is when I ask you about other anti-proteinuric agent, in which you also very fast. You don't know, you just need to know very fast. You didn't take a lot of time that like other people and most of the people. Sometimes we stun, then we were like, can you give me hint, things like that, waiting for examiner. But no. So sometimes if you're not sure, you can cut the time short. Is to say, sorry, I'm not sure, but I want to know up. I want to find out. You can tell honestly, which I think you did good, Okay. So any other question from the floor? I think no, right? Everyone is like almost lunchtime already. Okay, that's all. Eldon, you have no other question, right?
Thanks, Jumin. Thanks, Jumin.
Hey, no problem. Glad to help. So we will proceed with the last candidate, which I don't know whether the candidate is here or not. Let me check. Oh, it's not here yet. Probably we will just give about 5 minutes. Everyone can rest for a while. Meanwhile, anyone got any question with the new format? I mean, if you got any question, just voice out or you can put in the chat box. Sorry, I can't really see my chat box. Let's see got any message or not. Yeah, Jenny is all me. Okay. So we have last scenario. I will just give some time, and if it's maybe a bit rushed, then I will give to other people. Yeah, generally from the 3 scenario that we mentioned just now, while we're waiting for the other candidate. So you can see that the new format is almost same as BCC, nothing much difference, but just become more complicated in the sense of sometimes patient may have some non-medical issue or some issue that not related to the current presentation, something related to social, to the work and the stuff. Like for example, for this patient, like something related to the sexual activity, have difficulty because of all these symptoms. So these are all things that we need to be aware, especially in a new diet. And generally, if you treat this as a BCC, then you should not have any problem. But the problem is when usually we prepare for the previous format, we tend to be very jumpy, very, very jumpy, because we want to get the differential diagnosis fast, exclude the differential diagnosis as a very important targeted systemic review, and past medical drug history, social a bit, 1 or 2 questions, and then settle. So that's how we prepare for BCC. But for this clinical consultation, we are expected to do something like history taking. If you do a very targeted history taking, a good history taking, covering all aspects, actually 9 minutes is really enough. It's really enough. It's just that sometimes, unless the stamp is something that you don't know and you really struggle to find the differential diagnosis and you don't know what else to ask, and that was the time that we'll time to consume more time, and then cannot really perform well. So another thing is that always remember for this clinical consultation, we must spend good amount of time to examine patient. This is no longer like BCC, just touch and go, just touch a bit, listen a bit, showmanship a bit, okay, can get marks already. No, this is not like that. I believe that the new clinical consultations, the scenario that they're going to come about is definitely not something like a spot diagnosis anymore. You have to expect that the patient may have a normal diagnosis, a general diagnosis, not a rare disease, but something related to complication, something related to medication, something related to association of that condition, and may not be something like so straightforward like endocrine condition like acromegaly, go in or for acromegaly, the diagnosis may not be that straightforward already. And they may hire more surrogate as well compared to real patient. Or if the patient, usually the patient have difficulty to give history unless it's a very young patient. Usually the middle age to elderly difficult to give history. So usually they will have the surrogate as the patient next of kin, and that is the surrogate that will going to be trained and give history. So if let's say that's the case, sometimes you will not find much positive history from the surrogate, but you need to really focus whether there's any sign from the patient. If the patient is just like a bystander, patient is just someone that cannot give history, instead it's the surrogate that gives the history, you really need to think that can this patient have some sign that is important, because we cannot find any sign from any surrogate simply, but there must be a reason why they find certain patient for that purpose of the question. So if let's say that's the case, you really need to make sure that you really check the patient properly and don't miss out any important sign. Just like the first case, for example, the patient have a difficult to control asthma, and you really need to make sure you check for, and you must mention that I don't find any oral thrush or candidiasis. I don't find any cushingoid features. Those things are the important one that we really need to mention. Sometimes in their calibration sheet, they will not mention that. They will just mention the positive find features. And sometimes the examiner easily get carried away by a lot of things. They're not focusing much, and then they may miss out when you say something. So it's important for us that for this clinical consultation, since there's 2 stations now, we are talking about station 2 and station 5. So these 2 stations, we really need to make sure that we take our time properly. We got 5 minutes now to prepare a full scenario. Generally, if I got 5 minutes to prepare, like just like history station in the past, I will write most of the thing there. I will definitely make sure I will write the differential diagnosis to begin with, chief complaint, differential diagnosis. And before that, I will also make sure I write the role, what is my role and what is my role, what is patient age and name. Because your role is important. You don't want to go in mentioning that you are a doctor in the medical department, but the scenario is actually you're a doctor in the ICU. So you don't want to mention that wrongly. Some, especially UK examiner, I think local examiner not really particular about all these tiny details. UK examiner, they they look kind, they give mark also can be generous, but they really focusing on the communication. They're focusing a lot on the communication and also the details, the tiny details like this. If you are like not being professional in their opinion and you address people wrongly, and then if you're not empathic enough, it's very emotional. They may not be able to give you good marks. So just while we waiting, I don't have the mark sheet, right? Let me just open for a while. While we waiting, I just want to make sure that maybe this is the slide for the next session. But anyway, I just want to show this. So you can see, clinical consultation, just like BCC, carries all the marks, all the component marks. But if you look at usually, generally from experience, we all will pass the overall marking. Overall passing mark, definitely will pass. But usually we fail the component score, either by 1 component, 2 component, 3 component, regardless of what. Usually 1 component by just 1 or 2 marks. That's by experience. A lot of my friends, including myself also, I failed my first attempt by just 1 marks. So you will realize that the exam is not difficult. To get the passing mark for the total score is also not difficult. The difficulty lies to pass the component. You can see that for the total marks, previously was actually 172. You can see the 4 marks reduction is because there's 2 com skill now, and previously under the history taking, you got 4 more marks for the differential diagnosis. And because that one is being removed, that's why you get less 4 marks compared to 142, only 168. And you can see that the passing mark from previous 130 become 127. Okay. So you can see if you go by component, let's just go by component and just analyze this marking sheet. You realize that the component that you will fail easily, like really fail easily, is your comms. Look at this. Very high weightage. That's also another reason you know that UK examiner are focusing on this. They are very pro soft skill and very pro home skill one. Okay, they may not be very good or particular in getting the science physical examination. Some they are very particular in performing the physical examination correctly, but generally they are quite generous for this and this. And this also they're quite generous. Judgment also they're quite generous. But look at this com skill, communication component, and also the concern component. These two, I believe, will be the one that's really difficult to pass. And welfare is something very simple. If you don't do anything major, if you fail the station, also they will give you full marks in your welfare. Okay, they will give you full marks for the welfare. So you can see that welfare is generally easily score. Most of the time you almost get full marks one. Okay, but the one that you will really bring you down or make you fail is the component of communication as well as concern. This two is the one that we really need to do well in our communication station as well as clinical consultation, because these are all the marks form. Okay, that's why I'm focusing on just consultation for each session and just communication for another one session, because I feel that it's important to focus on these two components. I have no question that with adequate practice, short case, usually will pass, and usually the rest of the component we all are, when we prepare for exam, I believe everyone is already experienced enough. Most of the questions we can answer, no big major issue. But the main issue lies with this communication and concern. So you can see that if let's say you screw up one of the com skill badly, you fail that com skill, 4 marks gone, you only left with 12 marks, and you must get full marks in your 2 BCC, so-called 2 clinical consultation, and your another ethical communication station must be full mark also, or else you will fail. You can see that it's very dangerous. So let's say you say something wrong, like medical jargon in the com skill, they will bottom few marks. Like if one examiner bottom 1 mark also, it's already 2 marks. Okay, and let's say second scenario also you did not do very well, they also minus you for some reason. You got 4 mark reduction, you got 12 out of 16, you still pass. You can see. But let's say your clinical consultation, you did not communicate to the patient well, you're very stern, you're very strict, you don't show empathy, they may bottom you 1 or 2 marks there. And if they do that, then it brings you into a very dangerous zone, because you cannot pass a component of communication. I'm sure that most people will pass the total mark, but this is the thing that I feel in new format, this is the one that's going to kill most of us, most of the people. So please be aware, please really be empathic. Please adjust our tone when we speak to the patient. Make sure we adjust accordingly, and please address our concern and address the patient concern. And the concern usually when we address, some may ask us, very common question is, if we give a wrong diagnosis and we give a wrong answer to the wrong concern, will examiner still give you mark? The answer is yes and no, depending on the examiner. So some examiner, they are strict. If your diagnosis is wrong, you will get 0 here. Your clinical judgment definitely will not give you marks. Some will give you 1 mark, some will not give you. And your welfare definitely they will still give you, provided you have empathy enough. But your concern, usually they will not give full, they will give half mark. They will give half like that. Everything is like half. So if every examiner give you half mark, so your station only left half of the mark only. Okay, so this brings the question that your concern is also important. So please make sure that if you don't have time, if you are really limited, you must, regardless of how, last 2 minutes reminder, just ask about concern. Just try to get as much as you can, because that is the part that if you don't get enough, you will also fail the concern part. Okay, so the communication and concern is the one that I want to highlight. That's why I will focus next on the communication later on, after we finish today's consultation session. Okay, next we will proceed with Dr. Yo. Dr. Yo, are you ready? Can you unmute yourself?
Yeah.
Can? Yeah, you can hear, right?
Yeah.
Okay, so I will give you 5 minutes. You prepare for this scenario, and then we will start. I think you just join it. So I just want to refresh a bit. I think you have practiced a few times before with the new format. So usually the 5 minutes to prepare, then you have 12 minutes. Actually, in fact, yeah, 12 minutes. I will actually classify 12 minutes. 12 minutes for history taking and also examination. But generally, I will allocate about 8 minutes and 4 minutes, or either 9 minutes and 3 minutes for examination and history. And then generally during the last 3 minutes, there's no conclusion yet whether the RCP want to give a reminder at 2 minutes or 3 minutes. But regardless of how, I would say it's a wiser way to start addressing concern at the last 3 minutes, because the new format have more concern now, and sometimes you have to explain a bit lengthy, no? And you also need to, yeah, probably you're not there just now. I just want to tell about this slide because it's important. It's mentioned in their mark sheet. That's why it's important. So nowadays they give these 4 clues in outside the scenario. Any of the scenario for clinical consultation, they give this. They say not necessary to complete history first before examine. They expecting us to explain the probable diagnosis and to plan the management together with patients. So now they are expecting us to do this already. We cannot just mention that, oh, you need admission, and we need to work out further. You must mention that, okay, you might need to order blood test or maybe some scan. Okay, so might need to tell the patient and also discuss the option with the patient. Let's say it's something that is in their surrogate punya question, they will ask, and then we have to achieve some for simple agreement with them. Okay, and then we should also expect to address the patient issue, which is not including the non-medical issue like financial issue, social issue, working issue. So, and we always want to clarify what is the most important matter to the patient. Okay, in which we always ask in the concern that shouldn't miss that. But the additional thing is to focusing on not the diagnosis per se, but also the underlying other complex social issue that the patient may have, and also plan the management with the patient. Okay, so with that, I will give you 5 minutes. You are ready, right?
All right.
Okay, so let's start.
Sorry, just to clarify, the patient is a lady or guy?
Hello, can everyone hear me now?
All right.
Yeah. Okay. So let's start. Times begin now. This is Mr. Tan.
Okay. Hi. Good morning, Mr. Tan. I'm Dr. Yo from the medical clinic. Can I confirm you are Mr. Tan, 48 years old?
Yeah. I'm 48. I'm Tan here.
So, Mr. Tan, today we are here to discuss a bit about your health conditions, and I'm going to examine you later. Is that okay?
Yeah, sure.
So, I'm going to write down some notes during these sessions. Please be assured that everything we discuss today is going to be confidential, and my full attention will be with you. All right?
Okay.
Okay, Mr. Tan, can I know what brought you to the hospital today?
Yeah, doctor, I've been having bloody urine for almost 3 months now. Actually, it's almost 1 month now. So initially, it was really like straw color like that, but nowadays it's actually become worse. I'm very surprised to see every time I pee, the blood is actually full with blood. My urine is full with blood, just fine blood. I'm very worried, doctor.
I'm so sorry for what you have going through. Hopefully, by the end of the sessions, I'm able to help you out. All right. So, can I know a little bit how frequent you are having this blurry urine?
Yeah. So it has been here for the past 1 month, and it actually become worse. Previously, 1 month ago, I feel perfectly normal. I don't have any issue when I pass urine.
Right. Is it happen intermittently or is always there?
I feel it's always there.
All right. So, can I know is it worse in the morning, evening, or afternoon?
Yeah, generally throughout the day and night is also there.
All right. Okay. Can I know when you pass urine, does it change color?
Recently, yes, like initially just straw color. Now it's like fully blood red.
Okay. Can I know is it painful when you pass urine?
No, I don't feel any pain.
Okay, it's painless, huh? All right. Can I know do you experience others than passing out blood? Do you experience any bleeding from other place? For example, you vomit out blood
No,
or you vomit out coffee kinds of vomiters?
no,
Any blood coming out from your nose
no,
or from your eye, from your ear?
no,
No. Any blood coming out from your stool
no,
or the very black color stool that is very foul smelling?
no,
Right. Do you have any bruises or any swelling?
no.
All right. So can I know, do you feel, when you pass urine, do you feel a lot of hesitancy?
No, I can still pass urine quite smooth.
Okay. Um, can you, are you able to control your urine?
Yeah, I can.
Okay. When you pass urine, is it a lot like, you feel like you're not passing enough, it drips a lot?
No.
No, huh? What about at night? Do you go to toilet very frequently that you want to pass motion?
Pass urine, no. Pass motion also no.
Okay.
Not fit.
Do you have any loss of weight?
Yeah, doctor. I realized that I have lost about 15 kg in the past 6 months.
Okay. How about your appetite?
Yeah, I also have no appetite recently.
Okay. Do you experience any difficulty in breathing?
Yes, only when I do activities like carry objects or even do some simple activities, I will feel breathless. But at rest, I don't feel that.
All right. What about awareness of your heartbeats that you feel your heart is beating very fast?
Yeah, sometimes when I just resting doing nothing, I also feel seems like my heartbeat actually beats faster than usual.
Okay. Does anyone's comment that you appear very pale looking?
Yeah, I think my wife also told me that recently. I think maybe she said maybe a lack of sleep. My whole body seems pale.
All right. Can I know 1 month before this, do you experience any fever
No,
or any cough, runny nose, sore throat?
no,
All right. Do you have any diarrhea?
no,
Loose, no loose too, huh?
no, those two.
Can I know a little bit, do you have any rash anywhere?
No,
No rash, huh? Do you have any joint pains?
no,
Any skin tightness?
no,
Any limb? Do you feel like your hair is losing hair?
no.
No. Okay. So when you all right, do you have any skin lesions like skin changes?
Not that I know of.
Not that you know of, huh? Okay. All right. Um, so can I know do you have any medical history that I need to take note of?
Yeah, doctor, I've been having gout for almost 5 years already lah. Then initially it all started with all the joint pains over my foot as well as my fingers. But I also have a bit of swelling over my joint. But all that has already resolved. I used to take allopurinol, the medication that doctor always asked me to take, but I've stopped that like 1 year ago. I never take it anymore. So because I don't feel anything else wrong with me. Without the medication, I'm also fine.
Okay. So since you stopped the allopurinol, are you taking any other medications?
Yeah, actually, intermittently, sometimes I do take some traditional herbs because sometimes you have a bit of pain and also swelling. I'm worried this will come back, the real gout attack. That's why I'm taking these traditional herbs.
How long you have been taking the traditional herbs?
So the traditional herbs actually almost 1 year already.
Right. Other than traditional herbs, is there any other medication, for example, painkiller?
No, no. I know it's not good for kidney and also my heart. I don't want to take that.
Okay. Others than the traditional herbs, are you on any medication, for example, hypertension medications?
No,
No, or any medications that help you to pass motions or anything?
no,
All right. Do you have any surgical history that I need to take note of?
no, no, no.
Okay. Do you have any allergy?
No.
No, all right. Can I know, do you have any family history that I need to take note of?
Like for example,
For example, any amongst your family member, anyone's with easy bruisings, easy bleeding,
no, they don't have any blood disorder.
no blood
And
disorders, huh? Any
yeah,
family member with any, for example, hearing problems or visual problem?
no, but I think my father also got gout lah.
Your father got gout, huh? Okay. Any of your family members, they suffer from any kidney problems
No,
or sudden pass away?
no,
Any stroke among a family member?
no.
All right. Can I know what are you working as?
Yeah, doctor, I'm working as a lorry driver. So I always travel here and there to send the stock for my company.
Okay, what kind of stock you're sending?
Yeah, it's mainly all the boxes that I need to carry. Therefore, I feel very stressed because every time I need to work, when I'm carrying stuff, I feel I want to pass urine, and then when I pass out, it's all blood. I worry that this thing I cannot work like this anymore to carry heavy loads.
All right. Can I know, are you a smoker?
I only smoke sometimes, probably 1 week only, maybe 1 or 2 stick.
Okay, smoking is generally not good for your health. I will encourage you to stop smoking. Is that all right?
Okay, okay, I will try.
Any alcohol?
No, I don't drink.
Okay. I'm going to ask you a few more sensitive questions. It will help me to formulate some a good diagnosis. Is that all right?
Okay.
Are you taking any recreational medication, drugs or substance?
No, no.
No. Do you have a partner now?
Yeah, I'm married with my wife.
Okay. Sorry to ask, can I know other than your wife, do you have any other sexual partner?
Actually, before I got married, actually I did have once unprotected intimate relationship. That was like 1 year before I got married, and my partner was a lady, but subsequently I have no more this unsafe intimate relationship. She told me she's negative for those infection. I don't know.
Okay. All right. Sorry to ask, can I know, do you have any prolonged cough
No,
or any increase in phlegm productions?
no,
No. Any bone pain?
no.
Okay. Can I examine you?
Yeah, sure.
Okay. First of all, I would like to look at the peripheries to look at the nails. Is there any stigmata or infective endocarditis?
No stigmata or infected endocarditis.
Any pallor?
Yes, there is pallor over the conjunctiva and also the palmar crease as well.
Next, I would like to examine the pulse to look for any to examine the pulse volume, the pulse character.
Yeah, he is tachycardic. Heart rate is about 110, and then the pulse volume is equal.
Right. Next, I want to look for any bruises or any swelling over the limbs.
There's no obvious skin rash, bruises that you can see.
Okay. At the same time, well, take the opportunity to look at the joint. Is there any deformed joints?
Yeah, at the moment when you see the hands as well as elbow and also the feet, you cannot find any obvious tophi.
Okay. All right. Next, I would like to look at the conjunctiva. Is there any conjunctival pallor?
Yes, there is.
All right. Okay. Is there any scleral jaundice?
No scleral jaundice.
Okay. I would like to look at the mouth. How about the oral hygiene?
Oral hygiene is good.
Next, I'm going to perform abdominal examinations.
Mm.
Is there any tenderness?
No tenderness.
Okay. Is there any organomegalies, for example, hepatosplenomegaly?
No hepato or splenomegaly.
Okay, I will look out for any mass, especially over the suprapubic regions.
There's no suprapubic mass.
Right. Is there any tenderness over that regions?
Which region?
The
Suprapubic. No suprapubic tenderness.
Okay. I would like to examine if there is any ascites.
No ascites.
Okay. Subsequently, block the kidney. Is there any kidney blockable?
As you pull out the kidney, you realize that there's some mass and fullness over the right side. Seems like a kidney.
Right-sided kidney blockable. Okay. Next, I would like to further delineate the right-sided kidney. Is it regular or irregular surface?
Yes, regular smooth surface.
Smooth surface. Okay. Is it tender?
On deep palpation, it seems a bit tender.
All right.
Deep,
A bit. Okay. Can I know, is it descend with the inspiration?
Yeah.
Okay. Right. How big is the mass?
It's about fifth. It's about a width of your finger of your hand, 5 fingers. As I say, not necessary to measure.
Okay. All right. Can I okay, I would like to
2 minutes left.
abdominal lymph nodes or any inguinal lymph nodes.
No palpable lymph nodes.
Okay. Mr. Tan, so can I know, do you have any concern?
Yeah, doctor, what is the cause of the blood in my urine?
So first of all, Mr. Tan, after our consultations today, there's a few things going through my mind. Currently we need further workout. Number one in my mind, it can be because you are suffering from this gout and you have been stopping your medications, allopurinol, for the past 1 year. There might be a possibility that your gout is causing some stone in your kidney and affecting this problem. But another things that I definitely want to work out is because you actually have a very significant loss of weight, and also your appetite has been very reducing. I think I will need to rule out, unfortunately, sorry to say, I will need to rule out cancer in your case.
I see. Why, doctor? If this is cancer, but what is the cause of this?
So for cancers, sometimes is multifactorial. It causes primary regions. It can be because of environments. It can be because of health problems, right? But rest assured, Mr. Tan, for now, we will need further workout before we come out to confirm this is cancer.
Is this due to stone?
Sorry, says stone wouldn't cause cancer. Yeah, but I mean your conditions can be because of the stone.
Okay, all right. Okay, time's up. Okay, Dr. Yo, would you mind to tell me what is your working diagnosis and your differential?
So for my clinical consultation with Mr. Tan, 48 years old today, I'm thinking these patients, my provisional diagnosis can be a renal calculi secondary to the gout. In view patients has an underlying gout and he has defaulted allopurinol for 1 year. My other differential diagnosis can be this can be a urinary tract malignancy, for example, renal cell carcinoma or transitional cell carcinoma, in view of the significant history of a hematuria, constitutional symptoms, and also from the examinations, there is a right-sided kidney palpable, it's like tender, and measuring about 5 finger breadth. Yeah.
Is there any differential?
Sorry?
Any other differential diagnosis?
Other differential diagnosis, it can be because of urinary tract infections, for example, pyelonephritis. Can be also because of tuberculosis. Yeah. Other differentials can be because of bleeding as well. Bleeding.
Have you managed to examine for any renal angle tenderness?
Sorry, unfortunately, no.
Okay, never mind. Okay, so how will you work out for this patient?
So far for all, I would like to order a full blood count first to look at the hemoglobin level, to look for any evidence of anemia and also thrombocytopenia. Next, I'm going to send off a renal profile, mainly to look for any evidence of acute kidney injury. Liver function test to look at the albumin level, electrolytes, calcium, magnesium, phosphate, and also importantly, important thing is coagulation profile, INR level, and also APTT level. Next in line, I'm going to send off ESR-CRP, inflammatory marker, and also urine AFP. And I would like to send off a urine analysis, UFAMS, to look at any evidence of blood, CAS, and also protein, urine culture as well. Imaging wise, I will go with ultrasounds, KUB, and if necessary, can do a CT renal as well. All right. So in terms of management, after taking all the blood investigations, I will consider this patient for admissions in view patients had a significant history of anemia symptoms, and patient is also tachycardic on examinations. Depending on the hemoglobin levels, we might need to transfuse these patients. All right. And
other than admission, is there anything else you want to manage? How to manage the hematuria?
So first of all, I think we will need to involve the urology team, refer to urology teams. This patient might be benefit from the three-way catheter insertions and also bladder irrigations. next of all, look at the hemoglobin level and transfuse the patients accordingly. And yeah.
So let's say this patient has a mass in the right kidney, and proceed with a CT scan, found that it's actually a cancer, possible renal cell carcinoma. What would be the management?
So if this so first of all, we will need to involve the urology teams. And then we will need to order CT TAP for staging purpose, and need to involve subsequently arrange for renal biopsy as well to confirm the diagnosis.
Renal biopsy, is it necessary if, let's say, radiologically is evidence of cancer?
I think it's necessary. We'll need to look at the type of the cancer, so that and patient might be benefit from oncology referral as well.
So do you think nephrectomy is indicated in this case?
So if this patient is having an uncontrolled hematuria that is difficult to control and is not helping with the irrigations, and the bleeding is very life-threatening, then emergency nephrectomy can be considered. But
Okay.
for now, I think we can further work out.
Okay, all right. That's all. Thank you. Okay, ngam 20 minutes. Oh, very good. I think you get the timing very good. Your history, you are very, very firm. You can see that for everyone else that listen, you can see that how Dr. Yo do his history taking and examination, very systematic. He actually do it properly, go by HOPI, go one by one, did not miss out any important details. Okay. And examination also spent his time to really look for things. I mean, he only missed out the renal angle tenderness. The rest of it actually he did very well. Okay. And investigation management also good. You got any comments, Dr. Yo, for this case?
I think I my provisional, I should put the cancer first, because
Yeah.
I put the stones, so I think I should.
Yeah, so this patient has a very significant weight loss and appetite loss. On top of that, have a palatable right kidney. So the only sign in this patient is actually anemia and right palatable kidney, basically. Another thing is probably for Eldon and you, because both of you are doing a renal kind of case. So another thing is to actually ask any history of confusion, difficulty to sleep at night, to suggest uremia. Because we don't know the kidney injured or not, right? We don't know whether patient is uremic or not. So other than asking this, also ask whether you feel like feeling sick, want to vomit. All these questions is just kind of like screen through the kidney status in a way. And then another thing is to ask about the urine output. How is the urine? Is it P more or P less, or just usual? But I think you asked me about that. So it's okay. And yes, my question to you, only one question. What is the relationship between, probably not relationship, what is the cause of the renal cell carcinoma in this patient? It's a young patient, like 45. 48, sorry, 48.
Yeah.
Very young, right? I mean, I can see your history is very good, because I know that you are trying to exclude various causes of hematuria. You started off with quantifying the hematuria, excluding the UTI, and then and also you actually try to rule out any systemic bleeding on top of just hematuria for any orifice you try to ask, which is good. And then you ask about the kidney in terms of the urine per se, the urine characteristic, and then subsequently you try to elicit the etiology. And I can see that you try to screen for few, like you also screen for HHT, you also screen for ADPKD. I can see from your history, your reasoning is go one by one to exclude one by one. That is the way to go for exam. For your history and your examination and your discussion per se, you are definitely ready for exam. You just need to practice a bit more. But my only question for you is, do you know any association with traditional medication usage with regards to renal cell carcinoma?
Unfortunately, no.
So this is probably not expecting all candidates to know, or perhaps this is just a scenario I created myself. Anyway, yeah, the scenario is I created in such a way that the differential diagnosis should be something related to urate nephropathy, and that may actually cause hydronephrosis, causing right palatable kidney because of uncontrolled gout. And because of uncontrolled gout, he took traditional medication, and leads to another possibility. So in Chinese herb traditional medication, not every traditional medication is contain this component, but most of the Chinese medication that cause kidney impairment, we need to know about this nephropathy. It's called aristoloxic acid nephropathy. The reason why we need to know this is because it's very suspect thingy, but we need to know this because we need to suspect every traditional medication people that on traditional medication that have any kidney involvement, we need to think of urothelial cancer because it's very carcinogenic. So this aristocolic acid actually can lead to urothelial cancer, be it a renal cell carcinoma, ureter cancer, bladder cancer, you name it, from the urinary system. So that's why this patient is a bit tricky. Why the patient is so young and yet developed renal cell carcinoma? But even if you cannot answer this question, you can get full mark for this station. This is not the main idea to test the candidate to know the association, but to know that this is something dangerous, this is something cancerous, not just stone or any infection. Yes, pyelonephritis, you correctly mentioned. Yes, the recurrent UTI or any UTI, STD also important. But I'm just curious why you suddenly think of TB, because you order urine AFB and also you ask want to screen for TB, right?
Yeah, actually, because patient's age group is also patient age group is also I mean around middle age, and he has significant history of constitutional symptoms. But yeah, so
But you ask about cough, you ask about night sweat, everything, and also lumps and bumps also don't have, right?
yeah.
Yeah, I would expect you to actually put RVD in part of the differential diagnosis because you managed to get the history that he have an unprotected intimate relationship 1 year before he got married, right? And that part of history, he said that so-called partner maybe is negative, he's not very sure. And this part of history brings a door towards a diagnosis of RVD, huh? Because RVD can really manifest anything, huh? And the only thing, perhaps the negative thing is he does not have any GI symptom and no prolonged fever. That's the reassuring part. But this is something that I will put already more than TB in this scenario because he got high-risk behavior before that. No? Other than that, I think your approach and your diagnosis and your examination is all okay. Huh? I think it's very good. I got nothing to comment. Anything else you want to comment? Or anyone wants to comment anything?
Can I know how many concerns this patient have? Because I think I only managed to.
Yeah, so you will expect the patient to have 5 concerns. Just for new format of clinical consultation, even in the exam scenario or even when prepare for the question, is always 5 questions. Maybe more in the sense that sometimes if you look at the sample scenario, usually under the surrogate their so-called the actors sheet you will see that they will ask they will tell that, let's say for this patient, they will tell that, doctor, I've been having blood in my urine for how long? This thing has been getting worse. Then they will full stop and they will ask a question. Is this something cancer? They will put a question mark there. So maybe the next new format, the surrogate or the patient will be trained as such, meaning to say they give a concern question early, but that concern question is not part of the concern properly, but they're expecting us to actually answer that concern as well. So, and some of the thing that, for example, this patient also got one hidden concern that I mentioned just now. I say that issue with work, right? So you are focusing a lot on the diagnosis and the management of the condition. But remember that this patient also working as a lorry driver, carrying heavy objects, loads, and he is concerned that he may not able to work, correct? That was what in the history, right? So in regards to this, you also need to, if you have enough time, because I think towards the end, your time is a bit short. That's why you didn't manage to ask all concern. But regardless of whether, let's say you manage to ask all the concern, you should automatically tell the patient that, or maybe at that point he volunteered this history to you, you should already say something to address that part of concern. So if not, then you leave it to the back. If you remember, you tell the patient that I think it's a bit difficult for you for having so many issues. I believe that it's difficult for you to go for work. If possible, I can also refer to occupational health, talk to your employer and see how we go about it. You can just mention just a one short sentence like that. Because to me, the new format, they are expecting us to address various concerns, not just concern regarding the diagnosis or the management or the investigation, concern regarding the family members, whether they get the disease or not, concern whether they can afford the treatment or not in terms of financially, as well as this kind of concern whether they can work or not. So I think all these are also part of the concern that we should tackle. Other than that, I think you're considered very complete. Very good already.